Good evening, ladies and gentlemen. Welcome to day 6, the marathon web series on lymphoma, which includes the best of 16th ICML International Conference on Malignant Lymphoma, Lugano. Words fail me when I have this gentleman on the picture. Sir tirelessly has been enriching all of us, and even during this ICML Lugano, I have watched, and all of us have watched him right from logging in at 5:45 and finishing it off at 9:45. No wonder, sir, you are the teachers of teachers. You are the inspiring hematologist of India. Entire India is indeed grateful to you for bringing this. Thank you so very much, sir. Over to you.
Thank you, Dr. Manoj. Good evening to one and all. So we have this update in lymphoma, which includes the best of 16th International Conference on Malignant Lymphoma, held in Lugano just a couple of months ago. This webinar is brought to you by Mumbai Hematology Group. It is supported by INTAS, managed by Mice Ideas. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Rajesh, Mr. Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our international guest speakers, our chief guest of the day, Colonel Dr. Sanjeevan Sharma, our discussants who are eminent hematologists and medical oncologists, and you participants for sparing your evening. We are at day 6, the penultimate day, and we'll be ending tomorrow by 9 o'clock in the evening. Discussants today include Dr. Sandeep Shah, is consultant hemato-oncologist, bone marrow transplant, in charge of BMT Department of Medical Oncology at GCRI Ahmedabad, and also Hemato-Oncology Clinic, Vedanta Institute of Medical Sciences, Ahmedabad. Dr. Sachin Puneta, Associate Professor, Department of Medical Oncology at Tata Memorial Center, Mumbai. Dr. Mehboob Basade, Professor, Medical Oncology, bone marrow transplanter at the prestigious Jaslok Hospital, Sir H.A. Reliance Foundation Hospital, Safi Hospital, Bridge Candy Hospital, Mumbai. Dr. Manoj Toshniwal, Consultant Hematologist and Bone Marrow Transplant Physician, MGM Medical College and MCRI Super Specialty Hospital, Sidco, Aurangabad. Dr. Mahesh Rajashekharia, Head Department of Hematology, Hemato-Oncology and Bone Marrow Transplantation at Sparsh Hospital, Bangalore. Dr. Sunit Lokwani, Consultant Hematologist and Medical Oncology, Shalby Hospital, Jabalpur. Dr. Chandran K. Nair, Professor and Head Department of Clinical Hematology and Medical Oncology, Malabar Cancer Center, Thalassery. Dr. Deepak Charles, Consultant Hemato-Oncologist and Bone Marrow Transplanter, Esther, MedCity, Kochi. Dr. Abha Dubey, Consultant Hematologist and Hemato-Oncologist, Shalby Hospitals, Ahmedabad. And Dr. Ayan Bhattacharya, Director and Clinical Oncologist, Regional Cancer Center, Kuch Bihar, West Bengal. So these are our discussants for the day, and we are blessed by their kind presence. And now it's time to introduce our chief guest of the day, who is going to inaugurate this webinar and also give us some words of wisdom. And that's none other than Colonel Dr. Sanjeevan Sharma from Lucknow. Colonel Dr. Sanjeevan Sharma, all of you know him, doesn't require any introduction. Great friend of mine and has been associated with hematology for the last 3 decades. He's consultant hematologist, professor and head, Medical Division, Command Hospital, Lucknow. He has been serving armed forces as clinical hematologist since 2009. He has authored innumerable papers and peer-reviewed international national journals. He launched the first ever prospective clinical trial of TFR, that is treatment-free remission in CML, in India. He operationalized the hematopoietic stem cell transplant program at Armed Forces and Command Hospital, Pune. He started a once-a-week dedicated thalassemia clinics at Armed Forces. I'm grateful to him for having accepted the invitation and bless us by his kind presence. Now he's going to inaugurate this webinar for the day and also give us the words of wisdom. Thank you.
Good evening, sir. Sir, can I have your permission to say a few words?
Of course, Sanjeev.
Okay, sir. A very good evening to one and all, and special greetings to all our delegates who are here enjoying the rich deliberations on by the various speakers on the ICML proceedings of lymphoma. And it actually gives me it's an honor for me to have been invited when Dr. M.B. Agrawal asked me, one of the persons because of whom I have joined hematology, being inspired by Dr. M.B. Agrawal when I attended a conference way back in 2006 when I was not a hematologist, as you would have seen on my screen. I joined hematology only in 2009. But in early 2006, in January, I had an occasion as a general physician to come to Bombay and attend one of the meetings, and that really inspired. That was the time I was looking for which subspecialty to go, and immediately I made the choice. Of course, I jumped into the field of hematology, and thereafter it has been my life. Now, today's this initial inauguration is very special in the sense that Dr. M.B. Agrawal has asked me not to just speak about lymphoma or any topic per se, but to give all of you my perspective about this beautiful subspecialty of hematology which all of us are. So, in fact, when I started ruminating through my thoughts that what to speak in 3 minutes in front of all this august gathering, I first thought, let's first think of what any subspecialty in medicine, whether it's a recon surgery, whether it is cardiology or gastroenterology, what does any subspecialty of medicine gives that doctor? So I believe it's just two major concepts around which everything revolves. One is that any subspecialty allows us to revisit the basic concepts of physiology and pathology in that chosen part of our human body to such great details that we understand diseases and we understand its treatment much more lucidly than which we used to understand as, say, an MD. It's not that as an MD medicine we are not capable, but much more succinctly. And secondly, it allows, which is visible to the external world also, its practitioners to indulge in those highly specialized procedures and niche areas of technologies which other cannot. So I cannot do a cardiac catheterization. I cannot do an endoscopic ligation of a varices, which say a cardiologist or a gastroenterologist can do. So if these two are the basic things, then where does hematology take us? So now hematology firstly is not limited to any organ or a part of a body, like we are not identified as a heart doctor or the brain doctor or the liver doctor, which many of us our colleagues are, because our field encompasses the entire human body. Hematology actually integrates the concepts of cellular metabolism, signalings, the way the enzymatic systems in the body function, the genetics, how the somatic mutations, the germline mutations, they interact to cause human diseases. And of course, hematology allows us to practice in such niche areas like stem cell transplantation, now, of course, cellular therapy like CAR therapies, immunotherapies, of course, which are domain only of us. So if you were to just take a snapshot of the last 100 years where our medicine has been, I think we can divide it into three parts. If let's say today is the 20s, what medicine was as it was being practiced in 1920s, I think that was the time of great chemical interventions. Alexander Fleming in 1920 had just discovered the first ever antibiotic, that's the penicillin. And that started a great era of pharmaceuticals. So we had one after the other a host of antibiotics. So the exciting thing was then we had antihypertensives, anti-diabetics, the PPIs, and the host of medicine. I mean, the pharma industry just kicked up anything and changed the face of how we as doctors used to manage human diseases. So for the next 50 years, probably say from 1920s to 70s, the excitement was to find newer and newer chemical agent to address a human disease, so whether it was through antibiotics or anything else. 70s onward started when they started the intervention, the cardiologists, they started because their people started going into the coronaries and catheters. They developed these techniques of catheterization. Then, of course, started that era where people wanted to, or doctors wanted to reach those unreachable parts of human bodies where it was not visible earlier. So into the smallest branches, we could go inside. The endoscopes, the laparoscopes, they all came in. And that's why the cardiology, gastroenterology, pulmonology, it came boomed up like anything. What was possible only through a major surgery now could be done through a pinhole. And that's what for the last 50 years, we are seeing tremendous advancements. Now, maybe in the last 5-10 years, what we are seeing is that we as doctors are able to manipulate down to the cellular metabolism, down to the genetics. CAR T cell therapy is just an initial example how we can engineer a T cell into doing what we wanted to do. So what was just a proof, or what was just maybe a fiction, is now what we are actually doing. We are manipulating a cell to work the way it wants to be. And that is where I feel that the hematologists are most poised to lead the medical fraternity into this exciting new areas where gene therapy is knocking on our doors, and it is just a matter of time when, just like CAR T cell therapy, gene therapy is going to be the next baby, what interventions used to be. And that is where this branch of hematology, which all of us are so blessed to be in, we as all hematologists are looking at a very new exciting field. So just last week, I got a call from one of my fellows who was my MD student earlier, and now he's in the army. So after 5 years of MD, you're allowed to choose a subspecialty. So obviously he asked me a question, sir, I know you will tell me hematology, but can you convince me, because I'm a hardcore gastroenterologist. So I said, if you are a hardcore gastroenterologist, please go. If you want to live in the present, you please go and choose, because gastroenterology is a fantastic field. But if you want to look into the future, please go for hematology. Yesterday, I got a message. He's chosen hematology and he's now appearing for various examinations. So thank you for this note, and thank you, Dr. M.B. Agrawal, once again for giving me this opportunity to speak.
Thank you, Sanjeevan. That was a fantastic speech. In these 3 minutes, you have conveyed what many people would not have conveyed in half an hour. And thanks for converting at least one gastroenterologist into hematologist. That was great. Now I will just have the introduction of our first guest speaker. So we have Dr. Matthew Linning. He's Associate Professor, Internal Medicine, Division of Oncology and Hematology at Nebraska Medical Center, Omaha, Nebraska, USA. And he's going to speak to us today on peripheral T-cell lymphomas. Over to you, sir.
I'd like to thank the organizing committee for the invitation to present this evening there. And I'd like to compliment Dr. Sharma on some very admirable comments about the field of hematology and where things are going. As a cellular therapist who's been kind of on the front door of cellular therapy, and to the point where we didn't know what was going on, with regards to cytokine release syndrome, to now really looking to see how we can expand that field beyond B-cell lymphomas and even into the topic of today, into T-cell lymphomas. So with that, I'm going to share my slide here, or slides. Can you see my screen?
Yes.
All right, I'm going to put in slide present mode here. There we go. So I was asked today to talk on peripheral T-cell lymphomas and trying to give some perspective of the best of 2021 for the ICML conference, which was held virtually in Lugano. Obviously, this would have been better in person, but it was very good meeting virtually. And talking about, I found this quote from Winston Churchill that I think sums up peripheral T-cell lymphoma in one sentence. It is a riddle wrapped in a mystery inside an enigma. And I'll try and go through during my talk here about why I believe that is so, both from a pathologic standpoint, but also from a therapeutic standpoint. Here are my disclosures. So my objectives today are to discuss the process of subclassification of peripheral T-cell lymphoma. We are making advancements beyond peripheral T-cell lymphoma not otherwise specified as the most common subtype of peripheral T-cell lymphoma on a molecular level, so going beyond what we see under the microscope. And I'm going to talk about these advancements. We're going to discuss on the upfront treatment of peripheral T-cell lymphoma. As we know, the paradigm has shifted away from likely just everybody guessing CHOP, CHOEP, another induction strategy, to now potentially having more directed therapies based upon CD30, and this is based upon the Echelon-2 data. Then I'm going to go through some of the upfront studies in PTCL from 2021 ICML conference and see how those may or may not be impactful into the field. Then jump into really what has been now 10 years since really pralatrexate and romidepsin impacted the relapse and refractory space in PTCL, and kind of just recently in the last year and within the last months on where that space is going, and whether or not these therapies, which could afford patients benefit in this setting, were unable to really jump into the frontline setting. And then lastly, discuss the relapse refractory peripheral T-cell treatments from 2021 ICML and the early data that may lead to further subsequent monotherapies or combination therapies. So with that, I think that we all acknowledge that lymphomas have come a long way in the ability to make the diagnosis. You see here kind of 5 buckets under the WHO classification of lymphoid neoplasms, which was recently updated in 2016. We had some provisional diagnoses that became new recognized diagnoses, as well as continuing to slice the piece of the pie even thinner and thinner in regards to non-Hodgkin's lymphoma, and including mature T and NK cell neoplasms, or what we often classify under the umbrella of peripheral T-cell lymphoma. So again, getting more and more complicated. It's why I have to justify to my cancer center director why we need so many clinical trials in lymphoma, is because they can be so darn different, both under the microscope but also clinically. And so with this, we all know that peripheral T-cell lymphoma is not the most common subtype of non-Hodgkin's lymphoma. In fact, it makes up about anywhere from 5 to 15%, depending of all non-Hodgkin's lymphomas, depending upon where you set your GPS marker in the world on that day. And so if you're living in Asia, it may be way more common than our most common B-cell indolent lymphoma, like follicular lymphoma, and may rival that of our most aggressive non-Hodgkin's lymphoma in incidence in regards to diffuse large B-cell lymphoma, comparatively to all of our peripheral T-cell lymphoma subtypes. So with this, if you look at the International T-cell Project, now dating over a decade, and really try and play it forward, what are our most common peripheral T-cell lymphoma subtypes across the world, looking at not only North America, but Asia as well as Europe. You see that peripheral T-cell lymphoma, not otherwise specified, continued at this era to be the biggest slice of the pie, with angioimmunoblastic T-cell lymphoma following shortly behind. I think over time, and again, highlighting the geographical potential distribution of difference, is the lymphopath data from France, which showed that actually in this region, angioimmunoblastic T-cell lymphoma was more common than peripheral T-cell lymphoma, not otherwise specified. And you can see the other subtypes of interest, notably and most impactful with the therapeutic realm, had been, anaplastic large cell lymphoma, either ALK positive or ALK negative, but still both of those subtypes, even additively, still represented less than 1 in 5 cases of peripheral T-cell lymphoma. So I guess I want to come back to and just some paradigms and principles of the diagnosis of non-Hodgkin's lymphoma. And I talk about this because I talk about it all the way from the medical student level, when I'm giving lectures on cell of origin of oncologic malignancies, all the way to my fellows and colleagues, is that really coming back to peripheral T-cell lymphoma is just often one of the most difficult diagnoses to make for our hematopathologists. And so getting them the best sample possible can lead to increased confidence that you actually know what you're treating. And one of the ways that I know that we're kind of on the trail of a peripheral T-cell lymphoma diagnosis is actually when I know that we've gotten ample samples, either via an excisional or an excisional biopsy, as you can see, which is often surgically, gives them the most information. But even if it's been 7 days after the surgical procedure has occurred, that's when I know that maybe we might be heading down a peripheral T-cell lymphoma route, because often it leads to not only primary, secondary, but tertiary and quaternary stains or other procedures like T-cell gene rearrangement, and also looking for cytogenetic abnormalities. I really do feel that an incisional or an excisional biopsy is imperative to a diagnosis of peripheral T-cell lymphoma and allowing confidence in that diagnosis. That being said, a core needle biopsy, which is at least in the United States, has become a thing of surgeons saying send them to interventional radiology for a core. Sometimes can lead to a diagnosis of peripheral T-cell lymphoma, most commonly in the relapse refractory setting, because you know what you're looking for, and rather than kind of a needle in a haystack. And almost never is an FNA going to be enough of a sample, even with flow cytometry and cytology, to make a diagnosis of peripheral T-cell lymphoma, either in the upfront setting or in the relapse refractory setting. So how do we put this all together hematopathologically? Well, not only is the paradigm for morphology looking for homogeneous cell size, but also nuclear features, as well as the architecture, whether or not it is railroad tracking or following sinusoids, but also then going and looking at the phenotype. And we have classical T cell and B cell markers where you see more CD3 than CD20. You're always looking at the CD4:8 ratio. And then unique to T cell lymphomas comparatively to B cell lymphomas is that B cell lymphomas follow a very algorithmic pattern. CD5 negative, CD10 positive, CD20, CD19, so on and so forth. That can lead us down, for instance, a follicular a germinal center pathway. In T-cell lymphomas, what you're often looking for is aberrant loss or gain of pan-T-cell markers, most commonly CD5 or CD7 in those regards. However, you can see the double negatives as you move into like the gamma delta phenotype, where you see both CD4, CD8, or even moving into the NK phenotype where you start to look at CD56 expression. Lastly, that helps kind of, I will tie the bow on the diagnosis of T-cell lymphoma, often is looking at PCR for T-cell receptor gene rearrangements. And this is often, some stains can be done, whether or not looking at alpha, beta, or gamma delta. This can be done via flow cytometry, as noted up above, but also done now on immunohistochemical staining. And so often in peripheral T-cell lymphoma, again, this is a complementary test that you'll see a predominance of a single TCR gene rearrangement pattern, denoting clonality of the T cell rather than a reactive process. And I can tell you in the setting of even looking at with our COVID vaccine setting, when you can see lymphadenopathy as a result of the immune system mounting a response to a vaccine, one of the things that we can potentially see is reactive T cell proliferation, where you see a broad area under the curve of the T cell repertoire that occurs in response to immunogenic stimulation. So really the question is kind of how confident are we as in the field of T cell lymphoma when we make the diagnosis? Well, we're pretty darn confident when we have something to drive us, okay? So here you can see when you have large cells, which are anaplastic looking, but you see ALK is positive within a lymph node, that drives us towards an ALCL ALK positive. Often when you have a viral process, which is almost pathognomonic with the diagnosis, and in these cases, ATLL in regards to HDLV1, serologies or genotyping can lead to the diagnosis of ATLL. And it's not uncommon that you see a peripheral T-cell lymphoma not otherwise specified, or an anaplastic large cell lymphoma ALK negative, and then find out the person is HTLV1 positive, that diagnosis may change on what the pathology report says, but also leads to a change to the final report when the HTLV1 serologies come back. So I classically, in my peripheral T-cell lymphomas, regardless of the race or ethnicity of the individual, will check HTLV1 serologies. NK T-cell lymphoma, which is more common in Central America, as well as in Japan, China, and Korea, can be and is often seen with concurrent EBV infection. And again, this is EBV infection within the pathologic lymphocytes, comparatively to AITL, where EBV infection is often seen concurrently with the disease, but that EBV infection often is in the small B lymphocytes. You can see concurrent large cell lymphoma with AITL, but this is also an EBV-driven process of the B cells. So what about digging a little bit deeper into peripheral T-cell lymphoma not otherwise specified? I said that classically this has been the largest bucket of subtypes of peripheral T-cell lymphoma. So this is coming off of data on gene expression profiling that we had way back, went and done in diffuse large B-cell lymphoma when we had germinal center type B-cell, diffuse large B-cell lymphoma and activated B-cell that then was taken even into the further realm of being able to do this by immunohistochemistry with some confidence. So here, my colleagues at University of Nebraska in the lab of Javid Iqbal has been able to look at different PTCL subtypes and separate them into a PTCL TBX21 category or signature profile versus a PTCL GATA3 profile. And so while this was interesting, sitting as a clinical standpoint, we really wanted to know, was this clinically meaningful? And so you can see here that the prognosis of the GATA3, which is in the kind of the pink fuchsia curve, had a worse overall survival than those individuals who had a signature of PTCL TBX21. So was there any other differences kind of as you dug down to the cellular level? Well, PTCL GATA3 had greater genomic complexity. There was more deletions and mutations in the tumor suppressor genes. And there was more gain and amplifications of STAT3 and MYC. Comparatively, in the TBX21, there were fewer cytogenetic abnormalities and mutations in genes were seen in regulating DNA methylation. So this is important, I think, as we start to dig further and further into the therapeutic avenues of how do we crack this nut that is peripheral T-cell lymphoma. And so the next step, I think, is we've learned from nanostring and other technologies that really have only impacted 1% probably of all patients with diffuse large B-cell lymphoma, is bringing techniques that can be done in very few centers and bringing it to the other to the 99% of practicing hematopathologists and also hematologists out in the world. And so really taking this gene expression profiling and then bringing it to the immunohistochemical stain type of process. And here you can see different staining patterns that Dr. Amador and colleagues have really looked at and tried to validate not only in a training cohort, but also a validation cohort, noting that with fairly good confidence, you can recapitulate the outcomes via immunohistochemistry. And so when you really break it down via the immunohistochemical staining patterns, whether or not it's TBX21 staining or CXCR3, GATA3, and CCR4, peripheral T-cell lymphoma TBX21 represents about 2/3 of all PTCL not otherwise specified, and GATA3 represents about 1/3. Now, this should be noted that we are doing a lot better of pulling out our T follicular helper cell T-cell lymphomas out of the peripheral T-cell not otherwise specified, because we now know that PD-1 expression as well as CXCL13 expression can allow us to pull out and find more angioimmunoblastic T-cell lymphomas or T follicular helper cell peripheral T-cell lymphomas. And so really the goal here is to really shrink that bucket or that garbage bin of peripheral T-cell lymphoma not otherwise specified, but also be able to develop therapeutic pathways based upon these molecular markers. So we continue to split up the pie into smaller and smaller pieces, but I think we are making absolutely meaningful contributions to the field, and one that I think we will start to see being more impactful in eligibility to clinical trials over the next coming years. Pathology continues to do their best with current resources. This is one of the times I pick up the phone and I try to help lead them to water based upon the clinical scenario, especially in the realm of angioimmunoblastic T-cell lymphoma, where the body can go into absolute disarray at the time of initial presentation. And it's not uncommon that at least once or twice a year, we're making that diagnosis in the setting of an ICU. And in the less common subtypes, a second hematopathologist's opinion is often of significant utility. These are cases that end up on the desk of Elaine Jaffe at the National Institutes of Health, not infrequently. All right, so jumping into the therapeutic realm of initial treatment. So here's, I sat previously on the NCCN guidelines, and we would have great discussions over time about how do we lead forward and stay very broad in a category which can be very difficult to treat. Some of the movements that we've made in regards to peripheral T-cell lymphoma is not only looking at accentuating that appropriate clinical trials are preferred in this orphan disease, but also that multi-agent chemotherapy still drives a curative intent situation. Very, very rarely is early stage disease seen. And the paradigm of combination chemo radiotherapy modalities, there's lack of data for that for really a stage 1 peripheral T-cell lymphoma. One of the biggest things that we have been intervening on is interim restaging with PET-CT or CT chest, abdomen, pelvis. Typically, I've done this after 4 cycles. And why do I do this? Because about 40% of patients with peripheral T-cell lymphoma will have primary refractory or primary, even a smaller percentage will have primary progressive disease. And I really want to be conscientious that I'm not giving cycles 5 and 6, only adding toxicity and not deriving benefit. I am a believer that in patients who are in first chemosensitive response, proceeding towards either a clinical trial, which randomizes them to some maintenance therapy versus high-dose therapy and autologous stem cell rescue. I do look at the ability to tolerate the induction regimen as a litmus test to see whether or not I feel that they can tolerate a consolidation. If they're in CR1 and they've had multiple dose reductions or dosing holds due to toxicity, often in that population, I will observe and reserve either transplant discussion at the time of relapse, or they may not relapse at all. So peripheral T-cell lymphoma is really a disease that needs a bone. So it needs like a dog needs a bone. It needs drugs that work. And here is just now it's getting a little bit dated, but I think it still stands in 2021 on the different outcomes of all the subtypes of peripheral T-cell lymphoma. We can see here the best prognosis is in those individuals who have anaplastic large cell lymphoma that's ALK positive here in the yellow. This curve is likely to improve with the impact of brentuximab vedotin chip from the Echelon 2 study. Also, I think that will derive benefit from that study was the blue curve in ALK negative anaplastic large cell lymphoma. But really some of our most, worst peripheral T-cell lymphoma subtypes still exist in peripheral T-cell lymphoma NOS, angioimmunoblastic T-cell lymphoma, and then ATLL, which is again a regional diagnosis, but a devastating diagnosis and something that often the lymphoma is too far advanced for impactful therapy early on, which is why you see just a very sharp downturn in the overall survival in that disease. So I think it's important to understand the CD30 spectrum in peripheral T-cell lymphoma. We knew pathologically that anaplastic large cell lymphoma was pathognomically almost always CD30 uniform expression. And if you were seeing less than 80% CD30 expression in the neoplastic cells, It was not going to be ALCL. But there are other subtypes of peripheral T-cell lymphoma that do express CD30. One that we don't think about classically is NK T-cell lymphoma, and really because of asparaginase-based regimens and the improvement in response rates with those therapies, as well as the note of radiosensitivity of the disease, really brentuximab vedotin or other CD30 engaging strategies has not made it into the NK T-cell lymphoma repertoire just yet. Peripheral T-cell lymphoma NOS, as well as ATLL and AITL, can in certain percentages express CD30. One of the things that we had to go back and talk to our pathologists about is what truly does represent positivity. In their mind, positivity, negativity on a pathologic report may be a cutoff of 20 to 30%. But really in the era now of echelon 2 and brentuximab vedotin, we want to know the percentage of cells which are CD30 positive within the neoplastic cell to help make decisions. Why is that? I've hinted at this before. We went from the era of SGN30, which was a naked antibody, again, monoclonal antibody against CD30, to SGN35, which ended up being brentuximab vedotin, our antibody drug conjugate, with the warhead being MMAE, or a vinca alkaloid-like warhead. We all know the story of brentuximab vedotin in peripheral T-cell lymphoma, first being introduced into anaplastic large cell lymphoma, as well as classical Hodgkin's lymphoma, and just receiving, dynamic and practice changing overall response rates. You can see here complete and partial response rates in anaplastic large cell lymphoma approaching 80% overall response rate, CR rates in the 50%. But then the next thing that came about is, as I highlighted on the prior slide about the spectrum of CD30 expression in subtypes of peripheral T-cell lymphoma, was the finding that you could see responses in angioimmunoblastic T-cell lymphoma, as well as peripheral T-cell lymphoma. Now, that being said, the other kind of enigma or the riddle in this was that you could see complete responses in people who had almost 0% CD30 expression, as identified as some of the squares here for PTCL NOS, as well as some of the triangles in that bottom left-hand corner. But the other riddle or the other enigma was when you saw progression of disease up in the upper right-hand corner, especially in our peripheral T-cell lymphoma NOS, who had almost anaplastic-like large cell lymphoma CD30 expression. And so really this is this riddle, this is this enigma of peripheral T-cell lymphoma that we're still trying to solve. So because of these great response rates with brentuximab vedotin, the next initiative was trying to combine it with a backbone of chemotherapy. And I feel fortunate that I was involved in this early clinical trial of BV-CHIP and peripheral T-cell lymphoma. You can see here that there are many diseases that weren't anaplastic large cell lymphoma in this study. And you can see here even some of our toughest subtypes of peripheral T-cell lymphoma, ATLL, that express CD30 at differing percentages. Here you can see 98%, 25%. But people that would otherwise likely be just primary progressive to even our best, for instance, EPOC in AATLL, I think that that's a reasonable strategy. With BV-CHIP, you could obtain complete responses in this very difficult subtype. So we knew it was probably going to work in ALCL, but we found out that we think it could work with good overall response rates and CR rates in other CD30 expressing peripheral T-cell lymphomas. This also shows the durability here of BV-CHIP early, seeing both ALCL and non-ALCL really hug the curves together, again, but with very low numbers. So this led to the echelon 2 study, which was a global international study in 144 sites. Importantly, this was a double-blind, double-dummy study. The enrollment was the largest peripheral T-cell lymphoma study done to date at 452 patients, which again was BV-CHIP versus CHOP. People can argue around and around about whether or not CHOP was the right comparator arm, but for uniformity across the world, I think CHOP was an appropriate comparator. The primary endpoint was progression-free survival by independent review. You can see the secondary endpoints listed here. It should be noted that 75% of the patients in echelon 2 were anaplastic large cell lymphoma patients, either ALK positive or ALK negative. Now, this was a mandate based upon the European or EHA to have this a number of patients. Now, this did kind of lessen the impact for the other 25%, which represented PTCL subtypes of greater than or equal to 10% CD30 expression. So here are the curves that we've probably all seen, kind of looking at not only the PFS, but also the overall survival of brentuximab vedotin CHIP versus CHOP. I have to say, these are some of the best CHOP curves that I've seen, with the median follow-up of 3 years in peripheral T-cell lymphoma. But you can see here, regardless of those excellent CHOP curves, the 3-year PFS was an advantage of BV CHIP over CHOP, and there was a survival advantage of BV CHIP over CHOP in this study. So really, I think that this changed the paradigm of treatment of at least anaplastic large cell lymphoma, either ALK positive or ALK negative. And you can see this as displayed in the subset analysis here, favoring BV CHIP. It still did leave us with some unanswered questions here in angioimmunoblastic T-cell lymphoma, as well as peripheral T-cell lymphoma, where the confidence interval crosses 1, and even in angioimmunoblastic T-cell lymphoma, where there is a hint that of why maybe CHOP still did equally, and not statistically better than BV CHIP. So I guess it was the royal flush for peripheral T-cell lymphoma, in that BV CHIP was better than CHOP from a PFS standpoint. It was better overall in an overall survival standpoint, objective response, and complete remission rates. And so really, I think that this, asks the question of, now are we at an old pie, new pie, where we had the subtypes, and really all we were going to be asking our pathologists for are, is it CD30 less than 10%, or is it CD30 expression in the neoplastic cells of greater than 10%? And a complex disease, you would hate to think that that this was where we were going, is just really relying upon one stain. I don't think we were there quite yet with regards to the echelon 2, but we'll have to see. All right, so advancing initial treatments. So I'm going to dive into some 2021 ICML, but I think it's incredibly important to have this baseline data set in order to kind of jump into this discussion. So really, I wanted to highlight one trial in progress, which seems to be logical. And so this is evaluating non-systemic anaplastic large cell lymphoma patients, and so small study, into 2 cohorts, those that had less than 1% CD30 expression, and those who had 1% to less than 10% CD30 expression, and giving them BV CHIP for 6 to 8 cycles, with a primary endpoint of overall response rate. And this was opened early in 2021. So just out there that people are studying this sector. However, this may be difficult to accrue to, because this is a US study, because of the label that was given in this setting was CD30 expressing peripheral T-cell lymphoma. So even if it was 2%, 5%, you could go on and give this patient just commercial product. Not to say that this would be inappropriate, and this to say that this would be an appropriate trial to actually put those patients onto. And this is from Dr. Jagadesh and colleagues. The next is looking at a subset, which I said in certain regions, and this was a European study looking at angioimmunoblastic T-cell lymphoma, which in Europe is the most common peripheral T-cell lymphoma subtype. And really, there had been data about the impact of rituximab in AITL, really trying to take away that B-cell milieu that you can see kind of in concert with the AITL neoplastic cells. So maybe that interplay between removing those EBV positive B cells may help in the outcomes of AITL. You can see here that this was a retrospective study of 237 patients treated with either R-CHOP CHOEP or CHOP CHOEP from 2014 to 2018. Within this group, 100 patients received either rituximab plus CHOP or CHOEP. And when they broke down the data, it looked like there was equal grouping with regards to disease characteristics between the CHOP CHOEP arms, as well as the transplant versus no transplant consolidative arms, What you can see on the left here was really there was no real significant difference between the CR/PR rate between adding rituximab to CHOP or CHOEP. And if you looked at the overall survival between CHOP, CHOEP plus or minus rituximab, there was no significant difference in 5-year overall survival. I'm going to show you the transplant data in the next subset, but I think that this really does means that there is no additive benefit of adding rituximab in the upfront setting in AITL, at least in a retrospective series where you were unlikely to see a prospective trial. So what about if you just removed out, if you removed out chemotherapy in general, and you went to a non-chemotherapy, quote unquote, backbone or classic chemotherapy, and you used romidepsin and lenalidomide in newly diagnosed peripheral T-cell lymphoma. So this was studied in age greater than 60 individuals or those who are non-candidates for chemotherapy. So romidepsin was given at a less than approved dose at 10 milligrams per meter squared, but given on an approved schedule. And then a large dose of lenalidomide at 25 milligrams given days 21 to 21, very similar to a myeloma dosing strategy here for lenalidomide. And this is given for 12 cycles or 1 year. In this study, there were 29 patients enrolled, 55% of them were AITL, 38% were PTCL NOS, and a couple smattering of patients, I believe one EATL and one ATLL in this study rounded out the group. They had a short follow-up of only 8 months. They did note an overall response rate of 75% with the CR rate in this group of 30%. Picking on AITL, which is classically picked on from HDAC inhibitors, as well as IMiDs, because of its thought of having increased immunogenicity. In the AITL subset, the overall response rate was 84%, but the CR rate only had increased to 39%. Of note, and what I thought was interesting in this trial was that 2 patients went on to transplant in CR1. So again, kind of offering this trial, I guess that would be 2 patients over 60. And I think it is very difficult to, especially in a symptomatic disease like peripheral T-cell lymphoma, really discerning before you give 1 cycle of chemotherapy who are non-candidates for chemotherapy. So I think that this could have been a better trial if you had allowed 1 cycle of chemotherapy and then further made that decision point, as we've seen in other trials, which can be an equalizer in non-chemotherapy candidates. Nevertheless, the 3-year PFS was 36% and the 3-year overall survival was 51%. So it's going to be interesting to see where this goes, if anywhere at all, in the upfront setting of peripheral T-cell lymphoma. So my thoughts from these 2 studies from ICML and noting that this came in the precipice of Echelon 2 is that I believe that Echelon 2 has set the standard of care for ALCL, both ALK positive and ALK negative for peripheral T-cell lymphoma, for these peripheral T-cell lymphoma subtypes. I note that BV CHIP is available for other subtypes with CD30 expression. And again, we do not classify it as a 10% or greater. Really, the label just says CD30 expression. So one could take that as 1% expression. But again, it is unclear how much CD30 expression is necessary, and Dr. Jagadesh is doing that study. We still need to think about CD30 cold stone negative diagnoses on whether or not to use CHOP, CHOEP. There is recent data published finally on dose-adjusted EPOCH. And then we heard a little bit about Romi-Len from Dr. Wan from Cornell in her study. So what about consolidative treatments? So we know that transplant can improve some outcomes or additive outcomes or chances of cure for those chemo-sensitive patients. But again, the outcomes are quite poor in those patients who are not transplanted. And typically these are the patients that do not have chemosensitivity or have primary progression, have a very poor prognosis. So what about those patients who are in the Echelon 2 study? So this was a subset analysis of those who received BV CHIP in CR, and this excluded patients with ALK positive. So only 22% of the patients in the BV CHIP arm underwent a transplant. 38 went to auto and 76 went onto active surveillance. It should be noted that, again, all comers, excluding ALK positive and likely driven by the ALK negative group, that the PFS estimate still favored auto transplant following BV chip. And this is still my practice in those individuals who do have chemosensitive disease and tolerate well. Even after BV chip, I still think auto transplant is a worthy discussion, despite only 1 in 5 patients undergoing it in the Echelon 2 trial. Again, we'll have to really look at this data as it matures over time. So what about rituximab CHOEP plus transplant? So this is looking at Romi CHOEP and transplant. So this is another paper or abstract from ICML, which didn't look at looked at the outcomes of Romi CHOEP plus transplant. And when you compare it to the 5-year outcomes of CHOEP plus transplant, really in this trial, they saw an 18-month PFS upon interim analysis. And given the outcomes, the trial was aborted because the curves really overlapped to the historical controls of CHOEP in itself plus transplant when separated out by disease subtypes. And so this should be noted that the Romi CHOP randomized trial was a negative trial. And here we have data looking at the addition of romidepsin to CHOEP, really plus transplant, really kind of a kitchen sink approach, really did not improve outcomes with the addition of romidepsin. When you looked at going back to the rituximab CHOEP study, transplant improved the overall survival in this population with a fairly significant hazard ratio. So again, kind of while it was retrospective and all of the biases that can be in place in these situations, this hazard ratio was quite impactful for transplant in overall survival outcomes. Again, why I consider transplant as a reasonable option in first chemosensitive disease in peripheral T-cell lymphoma. What about allotransplant? So this was a ginormous retrospective study done in collaborative fashion between the CIBMTR as well as the EBMT around outcomes of post-transplant Cy-haplo versus match-related, match-unrelated donor transplants, and also looking at just a subset of T-cell depleted versus T-cell replete transplants. You can see here the breakdown of haplo match-related donor MUDs from that standpoint. It should be noted that reduced intensity regimens were used more commonly in the haplo group. On univariate and multivariate analysis, there was no significant difference between the haplo group and the other groups in regards to overall survival, PFS, and non-relapse mortality. And you can see here the 3-year PFS across the board in regards to the 4 subtypes that was done by Dr. Dreger and colleagues in a collaborative fashion. So again, very hard to do prospective studies in peripheral T-cell lymphoma from an allogeneic transplant standpoint. So my thoughts on this, again, additively here is autologous transplant consolidation appears to be a reasonable option, both after BV chip and after other induction strategies. And I think there's a very narrow window of time to do allo transplants, given the rapid relapses that can be seen even in effective therapies in the relapse refractory setting of peripheral T-cell lymphoma. That really makes you need to think hard about where you're moving. And lastly, I'm going to jump into relapse refractory PTCL and go fairly quickly. As we know, we have 3 agents which are approved. You've heard me speak upon brentuximab vedotin CD30 positive diseases, and this can be used in AITL. But what about belinostat and romidepsin, as well as the other pralatrexate? Belinostat, from the BELIEF trial, you can see here the AITL, there was an overall response rate of 46%, peripheral T-cell lymphoma NOS 23%, and ALK negative 15%. You know, really, this is about a 20 to 30% overall response rate drug with often very low complete response rates. That being said, if a response is seen, those responses may be durable from that standpoint. And this is in a belinostat and HDAC inhibitor given days 1 through 5 and then 2 weeks off as a schedule. versus romidepsin, which is also an HDAC inhibitor, looking at the relapse refractory setting. Again, if you break it down by different subtypes in over 100 patients here, you can see overall response rates, again, in the upper 20s, low 30s, with CR rates often being half of that, but an unfortunate median PFS of about 4 months. And you can see here, there may be a signal in those individuals. Again, more than half will progress very quickly. But if individuals do find an opportunity for response, there may be some durability from that standpoint. Pralatrexate was approved based upon the PROPEL study. Again, kind of looking here, we're dealing with overall response rates in the 20s to 30% ranges, with CR rates about half that. But again, disappointingly, median PFS is around 3.5 months. So again, you have to have a keen eye on, if you're using these therapies, that progression does occur, and those toxicities may be driven by the disease itself progressing rather than the medications. And so being conscientious to that as you move forward. So thoughts on just what's available to us in the commercial environments. The prognosis remains poor for individuals with relapsed refractory PTCL. I stated that allotransplant remains a viable option, but I believe that building on a romidepsin backbone may be difficult due to the recent removal of the label for relapsed refractory peripheral T-cell lymphoma. I think it'll be interesting to see how compendium listing with the NCCN guidelines handles this difficult situation where a drug is being pulled or a label is being pulled. That being said, I do believe that it will remain available for CTCL and may be listed for compendium listing to continue to use. I think it would be difficult to build on a backbone of belinostat due to the schedule of administration, and really we haven't looked at belinostat other than a daily dosing for 5 days. And then I think building on pralatrexate may be difficult due to the toxicity. All right, so in the last couple of minutes here, I'm going to go through some of the relapse refractory treatments from ICML of interest in peripheral T-cell lymphoma. So the first one is a combination of duvelisib, which has single agent activity in peripheral T-cell lymphoma with an overall response rate of 50% and a CR rate of 19%, and really partnering it with romidepsin. One of the issues with duvelisib as a gamma delta inhibitor, PI3 kinase inhibitor, is grade 3/4 ALT elevation was seen in 40% or a transaminitis, which can be seen in the class of PI3 kinase inhibitors. You can see here the combination led to an overall response rate on all comers of 58%. And it should be noted that this did afford 28% of those individuals to be bridged to an allo transplant. And really, I think here that is the key, is really finding that window of opportunity, even if it isn't coming off of intensive chemotherapy, that you can get there with some more novel strategies like romidepsin plus duvelisib. You can see of interest, the AITL and T follicular helper phenotypes. The overall response rate was 68%, so a little bit higher, but look at the jump up in the CR rate. So again, if you're trying to get people to an allo transplant, you don't need to bombard them with ESHAP or ICE. You can still use what may be quote unquote gentler therapies to get them to a bridge to an allo transplant. Unfortunately, there was not as much activity seen in CTCL, but be mindful that window of opportunity may be short, because in this field or in this population, the median PFS was at 6.9 months. Again, dating back to the romidepsin PFS as a single agent was right around 4 months. Importantly, there was no additive toxicity in regards to liver toxicity with the addition of romidepsin to duvelisib, but there was continued to be seen LFT abnormalities with the duvelisib. So what about romidepsin carfilzomib? So carfilzomib, is often used in myeloma as a proteasome inhibitor. This was a phase 1/2 study looking at trying to achieve the MTD, which was found to be 10 milligrams per meter squared of romidepsin, plus a lower dose than you would use in myeloma of carfilzomib at 20 milligrams for 2 doses, and then increasing to 40 milligrams with subsequent cycles. You can see here an overall response rate of 32%, a CR rate of 15%, and a median PFS of 4 months. Looking at this curve, this is very similar to romidepsin single agent. And this compound combination, I believe, is now will be abandoned based upon these results from Dr. Collins and colleagues. Next is a single agent, a new kid on the block, if you will, valmetastat. So this is a dual inhibitor of EZH1 and EZH2. We may have heard of EZH inhibitors from tazemetostat, which is approved in follicular lymphoma. And so this is now looking at this dual inhibitor in peripheral T-cell lymphoma. This was done in 45 patients with an overall response rate of 56%, a CR rate of 24%. Again, interestingly, the duration of response in those 56% of patients was fairly durable at 14 months with a median PFS of 12 months. Looking at the subtypes of interest, so overall response rates of 70% in AITL, 48% in PTCL-NOS, and 50% in ALCL. So I think that this is a promising agent that you'll likely see more of as we move into the relapse refractory peripheral T-cell lymphoma landscape, and maybe something from an AE profile that may be willing to build upon as the new backbone, erasing romidepsin into the future. So what about some letters and numbers drugs that are early in the phase? This is DZD4, I can't see it, 205, oops, sorry. So this is a JAK1 inhibitor. This was studied in 2 different dosing strategies at 150 milligrams in 27 subjects and 250 milligrams in 14 subjects. You can see here that there didn't appear to be, at least in these small subsets, a necessary dose response. And so it'll be interesting to see as this moves forward. Again, this is early data in T-cell lymphoma about what dosing strategy is used as well as what subtypes. And again, early data as the duration of remission was not reported in this. So look forward to this combination future in ASH. HBI 8000 or tazemetostat. So this is an oral HDAC inhibitor approved in China. This is looking at outside the Chinese population, I believe in Korea, of 46 subjects. It should be noted that the median time from last therapy was 96 days. So that, in my mind, is a little red flag in peripheral T-cell lymphoma that people could wait 3 months before getting on therapy. And so maybe this is a selected population, but the overall response rate was 46%. As noted with HDACs, people gravitate towards AITL. In this population, an 88% response rate here, but again, a median PFS of only 5.6 months. So this is where the molecular, we need to drive really these studies to really look at if there's any, GATA3 or TBX21 differences in these populations. One of the last ones that I'm going to talk about broadly is limperlisib. So this is an oral PI3 kinase delta inhibitor. It is at its phase 2 dosing was 80 milligrams daily, and it was a continuous dosing strategy. There was 30 patients in this study. The overall response rate was 70% with the CR rate of 33%. Again, kind of looking at PI3 kinase inhibitors and like duvelisib had a good response rates in AITL. This had an 82% response rate with a 46% response rate in PTCL-NOS. Interestingly, all grade ALT elevation was only seen in 15.8% of patients. There was no reported grade 3/4 transaminitis, at least in the abstract that I could find. Interestingly, this can be seen in other PI3 kinase delta inhibitors. It's just a mild rise. And I think at this point felt to be non-consequential increase in creatinine levels. But this was only seen in 10% of the patients. And a last interesting tidbit was there's no comment on colitis, pneumonitis, and again, grade 3 transaminitis in this abstract. So potentially longer follow-up, we'll need to hear about this delta inhibitor. And last one I wanted to point out before I end and take questions is sintilimab plus chitomide in relapse refractory NKT cell lymphoma. So we all heard about pembrolizumab and its activity in NKT cell lymphoma. This sintilimab is a fully humanized anti-PD-1 antibody. Chitamide is an oral HDAC inhibitor that is approved in China. I believe it can only be used in China. I haven't seen where it's been used outside of China. And so this was, I believe, sintilimab given at 200 milligrams, and the standard dosing of chitamide. It was 27 patients, overall response rate of 60%, a CR rate of 50%. And if you know about relapse refractory NK T-cell lymphoma, these are some of the fastest moving and hard to control diseases, especially after they relapse from asparaginase. The median duration of response is 13.3 months, 18 months estimated PFS of 52%, and an estimated 18-month overall survival of 76%. These are people that I'm trying to get to an allo transplant if they've relapsed after a asparaginase-based induction strategy. Often they've had radiation. And so this looks like a very interesting combination that I'd love to see, just like as was reported in Dr. Horowitz's study. I'd love to see, the ability to take these people to transplant, and I'm waiting to see further follow-up on this study at subsequent meetings. And so with that, I think novel targets continue to emerge through clinical trials. I brought up valmetastat, the EZH1/2 inhibitor, and this had strong single agent activity with good toxicity profile that I think would be a parable drug. HDAC inhibitors continue to show efficacy in AITL. I think we're waiting, and I didn't show any data on oral azacitidine, but I commented on some of the GATA3 TBX21 differences with regards to potential hypomethylating agents being effective in a subset of peripheral T-cell NOS, as well as AITL. And so now these are moving into the upfront strategies with azacitidine. I think combination trials with romidepsin remain disappointing, and we need to move beyond a romidepsin backbone. But again, it may be difficult with the approved belinostat and pralatrexate due to dosing frequency as well as toxicity profiles. And I think lastly, and most importantly, we need to continue to be willing to do clinical trials in orphan peripheral T-cell lymphoma subtypes, and really focusing on doing those trials in areas of high prevalence to discern efficacy. I think we've seen this when we talk about PD-1 activity in NK T-cell lymphoma, but we also need to be cognizant of that there could be the potential for toxicity. An example of that would be PD-1 inhibition in ATLL, which ended up being fatal. And so I think we need to continue to move forward to look at these signals. And if we do, we will continue to move the field of peripheral T-cell lymphoma forward and try and solve these riddles and break those enigmas. And with that, I will end and take questions.
Thank you so much, Dr. Mathewlini. That was a fantastic review. Pretty elaborate, and you covered everything that was new in ICML as well. We have some questions from the audience, and there is faculty here. I request them to open up their video and ask questions. I'll just take up one question from the audience, and that is, do you offer high-dose consolidation for high-risk ALK-positive ALCL?
That is a great question, and actually I do. I think the outcomes that have come from the BCCA, at least in the pre-echelon 2 environment, is that high IPI ALK-positive ALCLs may behave like ALK-negative ALCL. And so I have a very in-depth discussion, which is often with a young male, if you think about the most common ALK-positive ALCLs. And if they're presenting with an IPI of 4, right, they're not going to get to their, they're not going to get the 5th criteria. And I have seen this. I will have the discussion with doing a CR1 auto transplant, even if I'm using BV chip. In this setting. I know there's a lack of data to do this because as I was stating in the original transplant, no transplant data from echelon 2, they excluded that patient population. But I think without further data, it's going to be very hard to salvage these individuals after BV exposure. While the outcomes are good, they're not Hodgkin's lymphoma outcomes. And I think it's a very similar patient population in that regard.
Thank you. Another question is, would you try brentuximab in a relapse refractory cutaneous PTCL that responded to radiotherapy, but tends to develop new cutaneous lesions, biopsy proven within 6 to 12 months?
So I'm assuming this is a mycosis fungoides patient, or just like a gamma delta primary cutaneous situation. But either way, I think that, if you have large cell transformation and it's CD30 positive and it's diffuse and it's broken through other therapies and express CD30, I think brentuximab vedotin would be a reasonable choice. I think if you look across the spectrum of CD30 lymphoproliferative disorders that arise on the skin, you have lymphomatoid papulosis, which is a self-improving ulcerative skin condition that under the microscope, you can't tell if it's systemic anaplastic large cell, primary cutaneous anaplastic large cell, or LYP. There is data for BV in those settings. I think that my colleagues are trying to reduce the dose of brentuximab vedotin to try to see you may not need all of 1.8 milligrams per kilo to take care of those cutaneous diseases. I think if you're dealing with a systemic manifestation of ALCL on the skin, then I think completely brentuximab vedotin is an appropriate choice if they haven't been previously BV exposed, or even if they've responded and you put it back on the shelf and then giving them, if the disease comes back, to retrying BV. And we have that data both, I believe, in Hodgkin's as well as in anaplastic large cell lymphoma, that you can see responses in that setting.
The last question from the audience is, have you seen responses to brentuximab in CD30 negative PTCL?
Yeah, I'm going to go back to my point here is really we have to look at what is CD30 negative, right? So if you're just going off the path report, again, it may be the pathologist dichotomizing based upon expression, of less than 20% or greater than 20%. So really picking up the phone and calling your hematopathologist and asking, is this truly negative, or is it positive in 5% of the large cells or 10% of the large cells? I think I saw, or I showed you the Horwitz data showing that there were responses seen in very little CD30 expression. So I actually discussed with patients very early on, because of the PFS with romidepsin and pralatrexate, that if it's an AITL, I may try an HDAC inhibitor first. But even if there's low CD30 expression, I may try brentuximab vedotin, and I have seen responses with durability in very low expressing CD30 PTCLs in that regard.
Dr. Chandran, your question.
So the question is what is your comment on a role of allotransplant in CR1 in any of the subsets of PTCL?
Yeah, I'm very much in favor of if a peripheral T-cell lymphoma patient that I've gotten into a remission and consolidated with an auto transplant, relapses, I'm having that discussion right then and there before we start second line therapy about going to an allo transplant, and I'm having them meet with an allo transplant doctor right away. The one caveat to that is anaplastic large cell lymphoma. Per se, if I can, come up with a strategy, if they hadn't had a first auto, like an ALK positive ALCL or a DUS22 positive patient where I may not have consolidated them with an auto transplant up front, I would have given them BV chip and had the discussion. If they were low IPI, perhaps in a DUS22 mutated ALK negative ALCL, I may not have consolidated that person. That's a situation where I could really pull BV off the shelf again, have good chance of getting them into a CR, and then doing a consolidative auto. But short of that situation, I'm really, in tune to the very narrow window that we're going to have to get these people to an allo transplant. The other caveat that I'll put to that is just that you don't need to bombard them with chemotherapy in order to get them to an allo. Right. I think that you can use other strategies like a combination therapy to get them into a CR, because that's what you're needing. But what you need is a patient that's in shape to get an allo transplant and a remission. Right. There's a lot of times we can bombard them with chemotherapy and get a response, but then you look at the patient and they're not an allo candidate anymore. Right. And then when they do improve to become an allo candidate, guess what's also improving? Their disease burden, unfortunately. And so it's really this finessing of the disease. And really, it's a chess match that you're against the disease in order to play the right piece at the right time and know that, if you don't have all your ducks in a row, you'll miss that window of opportunity to take them to an allo transplant.
Thank you. One last question from Dr. Deepak.
Sir, a couple of questions on first one is on ALK positive ALCL. There are some protocols we still use a maintenance treatment. What is your take on that?
Yeah, I think that that's really still a research question, maintenance strategies. I think that it wouldn't be unwise. ALK negative ALCL, there is a protocol of BV-CHEP, so by Dr. Herrera at the City of Hope, which has reported excellent data on kind of a full kitchen sink approach, which is BV-CHIP plus transplant followed by BV maintenance. There are now BV maintenance trials ongoing in people who got BV-CHIP. One of my colleagues at Kansas University is doing that trial. I think just like the Athera trial in Hodgkin's lymphoma, if you can maintain the toxicity, right, of brentuximab vedotin, and when we start seeing, and I've learned this in Hodgkin's lymphoma, we start seeing the neuropathies not in the single digits of exposure to BV, but in the double digits, right? So when you start to get to doses 13 through 16 in Hodgkin's lymphoma, if you're using it as a maintenance strategy post-transplant in high-risk Hodgkin's lymphoma, really being keen on asking the right questions, because it's kind of like pralatrexate in my mind. One dose too many can lead to motor dysfunction or motor neuropathies that can take time to get back, and you just miss that one question on the sensory process that exists. But I am in right now. I think it's a research question, but it's also an economic question given the expense of the drug.
Thank you. We have run out of time, so we'll have to stop here. Thank you so much, Dr. Lenning, for.
You're welcome. Thank you again for the opportunity to come and speak. And I hope the environment changes such that one day I can visit India to meet you all face to face.
Thank you so much. Thank you.
You're welcome.
Wonderful day ahead.
Have a good day.
Good day. My pleasure to introduce the second speaker today. So we have Dr. Lisa Roth. She's Director, Adolescent and Young Adult Lymphoma Program, Associate Professor of Pediatrics, Pediatric Hematology Oncology, Associate Professor of Medicine, Hematology and Medical Oncology at Well Corner Medicine, New York. And she's going to speak to us on mediastinal large B-cell lymphoma. So over to you, Dr. Lisa.
Right. Thank you. Thank you for the introduction. Are you able to hear me? Is my audio working for you?
Yes.
Okay, perfect. Computer issues, but I think we've gotten that sorted out. So thank you for the opportunity to speak. It's a pleasure to be here virtually today and to talk about primary mediastinal B-cell lymphoma. And I will. Okay. So thank you for the opportunity to speak, and thank you to everyone for joining this morning and this evening to speak about primary mediastinal B-cell lymphoma. I'll talk a little bit about the biology of the disease and mainly about treatment strategies, both in the upfront and the relapse setting, and then in the end, focus a little bit on the direction where I think treatment is going moving forward with novel agents for this disease. So while primary mediastinal B-cell lymphoma used to be considered a subtype of diffuse large B-cell lymphoma, more recently the WHO has recognized this as a unique clinical and pathologic entity. And it really is quite distinct from diffuse large B-cell lymphoma. If you think of the cell of origin for many of the B-cell lymphomas that we treat, many are derived from the germinal center, including the GCB subtype of DLBCL and Burkitt lymphoma. And primary mediastinal B-cell lymphoma is slightly different, thought to be derived from the thymic B-cell, and the common molecular alterations that we see in PMBCL are listed here. And this has long been recognized. This is the original gene expression profiling done by the Scouts group, highlighting the differences between the GCB and ABC type of diffuse large B-cell lymphoma. And as you can see, PMBCL emerged as quite distinct from either subset of diffuse large B-cell lymphoma, as evidenced by gene expression profiling. And we understand that this now likely exists on a continuum with many similarities actually to classical Hodgkin lymphoma. PMBCL overlaps with classical Hodgkin lymphoma with regards to expression of CD15, CD30, occasional expression of CD20, And there likely is a continuum between classical Hodgkin lymphoma and primary mediastinal B-cell lymphoma, with gray zone lymphoma existing in the middle. And some of the immunohistochemical characteristics and tumor density are shown here. But this has been highlighted more recently by gene expression profiling, where you can see that PNBCL really does mirror CHL with mediastinal gray zone lymphoma somewhere in the middle. More recently, in addition to gene expression profiling studies, studies evaluating genomic alterations and sequencing has been performed in primary mediastinal B-cell lymphoma. And that's what I'm showing here on the right. This is work from Christian Seidel's group highlighting the common genomic alterations seen in PNBCL compared to other lymphoma subtypes. So the top two are comparing PNBCL, which is shown in blue, to large studies evaluating alterations in diffuse large B-cell lymphoma, as shown in A and B. And while you can see there is some overlap, PNBCL really does seem to have a distinct characteristic of molecular alterations, which is different from DLBCL. And on the bottom here, this is showing the common alterations identified in classical Hodgkin lymphoma from laser capture microdissection of Reed-Sternberg cells and comparing that to primary mediastinal B-cell lymphoma. And here you can see there is a significant overlap in the common alterations between Hodgkin lymphoma and PNBCL. This is data from Margaret Schiff's group identifying common molecular alterations in PNBCL and comparing that to Hodgkin lymphoma and diffuse large B-cell lymphoma. So this includes mutations, which are shown in black, as well as amplifications, deletions, and structural variants shown below. The common alterations do overlap in this study as well with classical Hodgkin lymphoma. The most common alterations being found in beta-2 microglobulin, which is important in immune evasion, TNF-AIP3 or A20, which is important in NF-κB signaling, as well as alterations in JAK-STAT signaling. Importantly, these tumors have amplifications frequently in 9p24, and this is the locus that includes PD-L1 and leads to amplification of PD-L1 and potentially sensitivity to checkpoint inhibitors, which we certainly have seen in Hodgkin lymphoma and now more recently in primary mediastinal B-cell lymphoma as well. So this illustrates some of the common altered pathways in PNBCL as evidenced either by mutation, amplification, structural variants, or deletions. Immune evasion seems to be a hallmark of PNBCL, similar to what is known in Hodgkin lymphoma. There are alterations in antigen presentation in MHC class 1, MHC class 2, and beta-2 microglobulin, all leading to immune evasion as well as upregulation in PD-L1 and PD-2. There are alterations in JAK-STAT signaling, which is also seen in Hodgkin lymphoma. This is due to alterations in SOX1, which are quite common, as well as STAT6 and JAK2, all leading to alterations in JAK-STAT signaling. XPO1, which is a nuclear transport protein, is also found to be altered in some cases of PNBCL. This is observed in Hodgkin lymphoma and some cases of diffuse large B-cell lymphoma as well. This is a potentially targetable pathway with selinexor. We also see alterations in NF-κB signaling. This is through alterations in TNF-AIP3 or A20, as well as REL alterations. And then transcriptional deregulation, which is seen both in Hodgkin lymphoma and diffuse large B-cell lymphoma. We see alterations in stage 2, as well as histone H1E. And these lead to a variety of novel targeting options in PNBCL, which I'll touch base on, which lead to potential for novel therapies. So PNBCL is also distinct from a clinical standpoint. It has unique features that are quite different from DLBCL, and some of those are listed here. This is one of the few lymphoma subtypes that actually has a female predominance, and this occurs predominantly in young adults. So it's truly a disease of adolescents and young adults within the pediatric population. This tends to occur in the older pediatric population and the younger adult population. As far as the stage of the disease, of course, these all have mediastinal presentation, and most are stage 1 or stage 2, although metastases to the lungs can occur. Extranodal sites and bone marrow involvement are uncommon at the time of diagnosis, although can occur certainly at relapse. And the vast majority of patients do have bulky disease. Of course, these are large mediastinal masses. They often occur with pleural effusions and pericardial effusions. And these patients can present quite ill. So to highlight some of the treatment and the relevant treatment questions that exist in this disease, I have a few cases that I've outlined of patients that I've treated with PMBCL. I thought that might help to kind of go through some of the major treatment questions that we have in this disease. So this is a 19-year-old who presented with cough, shortness of breath, and back pain. On physical exam, there was no palpable lymphadenopathy, but distended neck veins. CDC and CMP were normal. LDH was elevated at 716. On CT, there was an 11 centimeter mediastinal mass, pericardial and pleural effusions, and bilateral pulmonary nodules. Echocardiogram revealed a large pericardial effusion with tympanoid physiology, which certainly does occur not infrequently in this disease. And an urgent biopsy was performed, and the pathology was consistent with PMBCL. On a PET scan, the mediastinal mass was identified, as well as multiple pulmonary nodules, and no other sites of disease. So the first question for this patient is, what is your initial treatment approach? This still remains a question in this disease. There are a variety of chemotherapy approaches that are used in PMBCL, and no single standard of care. And I think the challenge in this disease is this is a very rare diagnosis. It's challenging to perform prospective trials. And so a lot of the data that we have on management of this disease comes from retrospective series. So a few prospective trials, but certainly not enough to dictate management of this disease. So there are a variety of approaches. So I'll go through both the adult approach to PMBCL as well as the pediatric approach. Certainly rituximab offers an advantage, at least on an R-CHOP backbone in PMBCL. And so rituximab and an anthracycline-containing chemotherapy regimen is standard of care in this disease. Often radiation therapy is given, although we are moving away from that more. And the various rituximab-containing regimens are shown here, with MACOP-B being common in Europe, R-CHOP historically being common in the US, although more and more moving towards dose-adjusted ECOG-R, which is historically given with far lower rates of radiation therapy than R-CHOP has been. The event-free survival on various series is shown here. And in general, the event-free survival for this disease with rituximab and an anthracycline-containing chemo regimen with or without radiation lies somewhere in the 70 to 80% range. The one outlier being a single-center prospective phase 2 trial that was run out of the NCI evaluating dose-adjusted ECOG-R, which had an excellent event-free survival at 93%, albeit in a single-center experience. So to review dose-adjusted ECOG-R, for those of you who are not familiar giving this is rituximab given on day 1, continuous infusion of doxorubicin, etoposide, and vincristine, with cyclophosphamide given on day 5, and a 5-day course of prednisone. The NCI has studied this regimen in a phase 2 single-center prospective trial. And of the 51 patients enrolled on this trial, outcomes were excellent, with a 5-year progression-free survival of 93% and an overall survival of 97%. And based on this study, many centers throughout the US and the world have adopted dose-adjusted ECOG-R as their standard of care for cancer. The multi-center experience with dose-adjusted ECOG-R has been reported in a handful of series, and as expected, while the outcomes are favorable, they are not as favorable as reported in the single-center series. Our group conducted a multi-center retrospective series. This was 21 academic medical centers throughout the US who reported outcomes for both children and adults with PMBCL treated with dose-adjusted ECOG-R. And among the entire cohort, event-free survival in the adults was 87%, in the pediatric patients, 81%. There was no statistical difference between these two groups. So again, showing favorable outcomes with dose-adjusted ECOG-R, but not quite the home run that was reported. One of the main questions we have is dose-adjusted ECOG-R superior to R-CHOP in PMBCL? And We really don't know the answer to this. These have not been compared head-to-head in this disease. The Alliance CALGB 50303 trial, which was a large phase 3 randomized trial comparing dose-adjusted EPOCH-R to R-CHOP in patients with diffuse large B-cell lymphoma, did allow enrollment of patients with PNBCL. However, there were very small numbers. So of the almost 500 patients enrolled on this trial, only 35 of them had PNBCL histology, and the study was certainly not powered to compare R-CHOP versus dose-adjusted EPOCH-R in PNBCL, although within that group, there was no significant difference. There was also a large retrospective series that evaluated patients with PNBCL treated at major academic medical centers in the US with dose-adjusted EPOCH-R or R-CHOP, and there was no statistical significantly difference in progression-free survival, again, in this retrospective series. But these never have been compared head-to-head in a prospective trial powered to identify any potential differences between the two regimens. So what about the pediatric approach? In pediatrics, primary mediastinal B-cell lymphoma has historically been treated on treatment regimens that are designed for mature B-NHL, which in pediatric patients is predominantly Burkitt lymphomas. These very dose-intensive, short-course regimens designed for Burkitt lymphoma, but used to treat Burkitt, diffuse large B-cell lymphoma, and PNBCL. This is a summary of some of the larger series that have enrolled patients on these trials and focusing specifically on outcomes in the PNBCL group. And you can see event-free survival hovering in the high 60, low 70% range. And how does this compare to how children with diffuse large B-cell lymphoma fare on these trials? The patients with PNBCL have inferior outcomes. This is a large LMB 96 study, again, studying dose-intensive regimen for mature B-NHL, and as the outcomes were quite favorable for patients with diffuse large B-cell lymphoma, with an event-free survival of 85%, but with a 5-year event-free survival of 66% in mediastinal large B-cell lymphoma. And it should be noted that these are historic trials without rituximab at the time of this study. So given the very favorable outcomes with dose-adjusted EPOCH-R in adults, this regimen was evaluated in an international prospective phase 2 trial in pediatric patients. This study has been reported in abstract form and should be published soon. There were 46 patients with PNBCL enrolled on this trial, and the 3-year event-free survival was a disappointing 69%, which is what's shown in the black bar, which overlapped completely with historic controls. We also studied pediatric patients in our retrospective series. In that series, there were 38 pediatric patients with PNBCL treated with dose-adjusted EPOCH-R. The 3-year event-free survival in that series was higher at 81%. However, these are very small cohorts, and the confidence intervals are overlapping here. The BFM group has also reported their outcomes treating pediatric patients with PNBCL with dose-adjusted EPOCH-R comparing to their historic trials. The data for that is shown here. This is the largest series of pediatric patients, and here the 5-year event-free survival was 84%. So there's not much data that this is all that different from adults. These are small numbers with overlapping confidence intervals, and unfortunately not identifying one single superior regimen the potential promise for dose-adjusted EPOCH-R. So back to our patient, what is your initial treatment approach? There really is no evidence that one regimen is superior to others. I think any rituximab containing rituximab and anthracycline containing chemotherapy regimen would be appropriate in this disease. The standard of care at our center is dose-adjusted EPOCH-R. So continuing on with this patient, the patient was treated with 6 cycles of dose-adjusted EPOCH-R, and the end of therapy PET was performed after the 6th cycle. It showed resolution of pulmonary nodules, but persistent PET avidity in the mediastinal mass. And the pre-treatment and therapy imaging are shown here. The SUV uptake was greater than the liver, potentially substantially greater than the liver, with a Deauville score of 5. And so I think this is kind of the most common question that I get from practitioners, is what to do with persistent PET avidity at end of therapy without frank evidence of progression. So what would you do in this scenario? Options to consider include radiation therapy for this patient. Would you just continue to observe this patient, biopsy that area to determine if there is residual disease, or salvage therapy and autologous stem cell transplant? I think this is one of the great unanswered questions in PNPCL, is how to interpret end of therapy PET. What is the role of radiation? I think this is kind of the most common thought at the end of 6 cycles is, does this patient need radiation? And does this end of therapy PET help to guide who would benefit from radiation and who might be able to be spared radiation and the potential long-term toxicity? I think the role of RT is not well defined. Retrospective series that are performed among adult series have conflicting results. And regimens without RT have reported excellent outcomes. But again, we really don't have a great way of identifying those patients who are at higher risk of relapse. So this is a series that evaluated SEER data of patients with PNPCL treated with combined modality therapy with chemo and RT versus systemic therapy alone. And here in this series, you can see superior outcomes for those patients who received RT. And here's a conflicting series also looking at super data, patients with PNPCL treated with radiation versus chemotherapy alone, with no survival advantage for those patients who received radiation. And so I really think the jury is still out here on when radiation should be used in this disease. And if we can all agree in this young and predominantly female population that avoiding RT while maintaining excellent outcomes is a high priority. RT use in PNPCL does seem to vary based on the chemotherapy backbone, and I'm focusing here on RCHOP and dose-adjusted ECOG-R. These are retrospective series evaluating patients treated with RCHOP and reporting the percent that received RT. Historically, the vast majority of patients treated with RCHOP have received RT, although this was a large retrospective series reported last year in Blood, where patients in the PET era evaluated by PET at the end of treatment were PET negative with Deauville scores of 1 through 3 were spared RT, and only 28% of patients in that series received RT with excellent outcomes. Dose-adjusted ECOG-R, of course, is far less frequently used in combination with radiation, also with excellent outcomes. So can PET-CT be used to determine who should receive RT and who will likely have an excellent outcome in the absence of RT? The NCI extended their cohort with a total of 88 patients and reported the end of therapy PET-CT Deauville scores and outcomes for these patients. And you can see patients with a negative PET with a Deauville score of 1 through 3 do fare better than those with a positive PET. But even those with a positive PET, the vast majority of those are cured of their disease. And the treatment failures are listed here below. So 69% of patients had a Deauville score of 1 through 3, and that was 55 patients with only 1 treatment failure among them. Deauville score of 4 occurred in 21% of patients, and even these patients had relatively favorable outcomes with only 1 treatment failure among the 17 patients with a Deauville score of 4. And the Deauville score of 5 clearly are the worst players here, with 10% of patients having a Deauville score of 5. Now, this is, of course, going to include those with frank progression, and 4 of those 8 patients were treatment. We also evaluated end of therapy PET-CT in our retrospective series. Here, outcomes are divided by Deauville score. You can see 1 through 3 do clearly group together here. Deauville for still excellent outcomes with an event-free survival around 76%, and clearly inferior outcomes among those patients with a Deauville score of 5. So what we can conclude from what we know about PET-CT now is that this is an excellent negative predictive value. So the negative predictive value in our series was 96%. If you have a negative PET-CT at the end of therapy, you can feel confident that your patient is in remission. And the positive predictive value of an end of therapy PET is still quite There are patients that have frank progression, those with a Jovial 5 and new lesions that are clearly very high risk. But there's even a population of patients with Jovial 5 that are challenging to interpret, and the positive predictive value is quite low. And I think advanced diagnostics looking at metabolic tumor volume might be the answer here to how we can utilize PET to more accurately predict who is likely. So back to our case with a Jovial score of 5 with no anatomic progression. What would you do? Again, there's really no right answer here, but I do tend to observe these patients with very close follow-up, repeat imaging in about 6 to 8 weeks, and really follow the anatomic measurements here. If there's any concern for increase in size of the mediastinal mass, the lymph nodes, that's certainly concerning, and those are the cases that tend to progress. However, if the patient continues to have PET-avid disease in the absence of any other signs concerning for progression, I continue to follow those patients, and that's often the case. These areas remain PET-avid for quite some time. I tend to conduct serial PET images, and I've ultimately stopped doing this because the area can remain quite PET-avid, but with no anatomic progression in patients who go on years and years without any evidence of disease. And so I think PET at the end of therapy does have some utility, but it's very challenging to interpret a positive PET, and I put more weight into the anatomic CT measurements here, and try to observe these patients, avoid biopsy if we can, because there's a lot of false negatives in biopsy here. It's kind of a challenging region to access, difficult to interpret a negative biopsy, and follow these patients very closely. Okay, so moving on now to a second case. This is a 26-year-old female with stage 2 PMBCL treated with dose-adjusted ECOG-R. She completed 6 cycles without radiation. At the end of therapy, PET CT was reassuring with a Jovial score of 3. However, 2 months after completion of therapy, she develops fever and chest pain. Imaging is performed, which shows an increase in the size of the mediastinal mass, an SUV of 12, and no other lesions. And biopsy confirms PMBCL. So how would you treat this patient? First of all, I think biopsy confirming disease is quite important. You can get compound lymphomas in these patients, with Hodgkin lymphoma being observed at the time of relapse, as well as gray zone lymphomas. And so the repeat biopsy here, I think, really is essential in these cases. And then once you've confirmed relapsed or refractory disease, the question becomes how best to treat these patients. And the options to consider, I think really all 3 of these are radiation therapy, traditional chemotherapy followed by autologous stem cell transplant, or novel agents. So as far as the clinical characteristics of relapsed and refractory PMBCL, the treatment failures tend to occur early. Median time to an event in most serious is between 6 and 12 months, and the vast majority of relapses occur by 18 months. There's occasional late relapses, but the vast majority occur within 18 months of treatment. The sites of recurrence can vary here, so certainly in the mediastinum, but also parenchymal organs, kidney, liver, and ovary, and bone marrow and CNS disease, and that's often parenchymal CNS disease can occur at the time of relapse. We really don't have great data on outcomes for relapse and refractory PMBCL. I'm showing you here 2 series on the left from the pre-rituximab era, with quite dismal outcomes for patients with relapsed and refractory PMBCL, with a 2-year overall survival of 15%. And then on the right, much more encouraging data in the rituximab era, although be it from a single center. This is the Sloan Kettering experience among 60 patients with relapsed and refractory PMBCL, with an event-free survival of 57% and 3-year overall survival of 61%. So I think there's still work to do to understand how these patients fare and where novel agents really should be introduced in the sequence of their treatment course. What is standard care for relapsed and refractory PMBCL? I would consider RT if the disease is confined to the mediastinum and the patient has not received prior RT. In the NCI series of dose-adjusted ECOG-R, patients in this scenario were successfully treated with RT, and so I think if in the right scenario, this could be an appropriate treatment approach. And in all other cases, treatment is similar to relapsed or refractory diffuse large B-cell lymphoma, so that's reinduction chemotherapy and autologous stem cell transplant. However, I will say more and more novel agents are being moved further up in this disease. And over the next few slides, I'd like to go over some of the novel agents, how they've fared in clinical trials, and where I think they're moving as far as where they should be placed in the sequence. So this kind of highlights the various approaches to targeting PNPCL. There's a lot of potential targets here. First, we have deregulated receptor signaling with alterations in both JAK-STAT and NF-kappa B that could be targetable. JAK-STAT by JAK inhibitors, NF-kappa B by proteasome inhibitors. There's also multiple targetable cell surface markers in this disease, notably CD20, which of course we're already targeting with rituximab, CD19, which can be targeted either with bispecifics or T cells, and CD30 with rituximab vedotin. And then, most importantly, the program death ligand axis is dysregulated in PNPCL. Most of these cases have either structural alterations or mutations in PDL1 or PDL2, which lead to upregulation. And this is a disease similar to Hodgkin lymphoma that lives in a privileged immune microenvironment that's kind of ripe for immune targeting successfully, as has been done in Hodgkin lymphoma. So over the next few slides, I'll go through some of the data on novel agents in PNPCL and where we're moving. So first, JAK-STAT signaling, certainly quite relevant in this disease and rational to evaluate JAK inhibitors. Ruxolitinib was studied in PNPCL. This was a pilot study among 20 patients that enrolled patients with both Hodgkin lymphoma and PNPCL. Unfortunately, there was only one partial response among the 6 patients with PNPCL, and that was compared to more favorable outcomes that were observed in classical Hodgkin lymphoma. And all 6 of the patients with PNPCL rapidly progressed after the first or second cycle of treatment, and so this is not thought to be very active. Moving on to brentuximab vedotin, kind of a similar story here actually for this as a single agent. There was a phase 2 trial that was conducted in relapsed and refractory PNPCL. 15 patients were enrolled. Among those, there were 2 PRs and no CRs for an overall response rate of 13.3%. The duration of the responses was quite short at 3 to 4 months. And so this trial was stopped for drug inefficacy. And so I think brentuximab vedotin as a single agent is not very active in this disease, but as I'll get into, I think still does have a role in combination therapy. CD19 CAR T is certainly something that we are considering more and more in our patients with PNPCL with relapse and refractory disease. And I think something to keep in mind as these agents move further up into treatment in diffuse large B-cell lymphoma. So adults with PNPCL were included in the phase 1 and phase 2 trials of the CD19 CAR Ts. CRs were reported in some of these PNPCL cases, although these were very small numbers on these trials and kind of insufficient to make conclusions specifically about this histologic subtype. And as you know, we now have 3 CD19 CAR Ts that are approved in aggressive B-cell lymphomas, and so patients with PNPCL are eligible to receive these after having failed 2 lines of therapy. This data came out earlier this month. This is the real-world experience of patients with PNPCL treated with axi-cel. So this is a multi-center study that evaluated patients with PNPCL, 33 of which were treated with axi-cel outside of a trial. One of the patients had a complication and was deceased prior to receiving therapy. So by intention to treat analysis, the overall response rate was 76% and the CR rate was 67%. So quite encouraging data. Median time to best response, 29 days. Again, retrospective series outside of a clinical trial, but quite encouraging that CAR T is active in PNPCL. The 2-year progression-free survival was 64% and overall survival 78%. And I think we'll need to watch this data closely in PNPCL as we do in diffuse large B-cell lymphoma to determine just how durable the response to CAR T is for these patients. But certainly something that I consider in all of my relapse and refractory patients who may not immediately get into a CR to autologous stem cell transplant. And then lastly, what is the data for checkpoint inhibitors? So pembrolizumab has been studied in PNPCL, both in phase 1b and a phase 2 trial. The overall response rate from the phase 1 trial among 21 patients was 48%, with a CR rate of 33%. And the phase 2 trial, similar overall response rate of 45% among 53 patients, and a CR rate of 13%. And the basis of this trial led now to FDA approval for pembrolizumab, specifically in relapsed refractory PNPCL. And then more recently, nivolumab has been evaluated, and here is the role for brentuximab vedotin. Nivo was evaluated with brentuximab in relapsed refractory PNPCL. Among 30 patients, overall response rate is 73%, with a CR rate of 37%. So I think this is a very promising combination in relapsed refractory. So back to our patient, how would you treat her? And I think there are really a variety of ways that this could be approached. This is a patient who did not receive RT, who has disease confined to the mediastinum. So I think radiation alone is an option. Chemotherapy followed by autologous stem cell transplant, certainly an option in this patient. And more, I've actually been moving the novel agents into the second line, particularly Nivo and DV as a mechanism to get patients into a CR to autologous stem cell transplant. So I think any of those three would be reasonable. And so to kind of summarize the two cases here, this is again my proposed treatment algorithm. So there's a variety of ways to do this, but this is how I approach the treatment to PNPCL, which upfront is to start with a rituximab and anthracycline containing chemotherapy regimen, and I use dose-adjusted EPOCH-R. At completion of that, perform a PET CT. And again, a negative PET CT, I do think it's a good indication of a CR. Positive, far more challenging. So Doble's of 4 or 5. I think either radiation or observation is reasonable for these patients. I tend to observe, especially when they're treated with dose-adjusted EPOCH-R. And of course, any progression of disease or progression after a CR goes to this arm here for relapsed and refractory disease. I do consider RT if disease is confined to the mediastinum and the patient hasn't received RT before. And then in all other cases, rituximab plus reinduction chemotherapy, and then once in a CR, autologous stem cell transplant. And as I said, I have been moving the novel agents, particularly checkpoint inhibitors and rituximab vedotin, a little higher up. So where do I think we're headed in PNPCL? I think one of the priorities is to optimize outcomes while minimizing long-term toxicity. This is a very young population with many life years ahead, and so considering things like radiation exposure, cumulative anthracycline dose, toxicity related to fertility is quite relevant for these patients. Defining the role of RT is a priority in this disease, and I think minimizing RT while maintaining outcomes certainly needs to be a high priority. Understanding how we can best use imaging to risk stratify patients and avoid RT when feasible is going to be quite important. And I think advanced mechanisms to study PET will potentially elicit a more accurate mechanism to determine who is at higher risk of relapse. And then among the novel agents, checkpoint inhibitors are quite exciting, and can these be moved into the upfront setting? And that's something that our group has been very interested in studying. And so over the next few slides, I'm going to review a randomized phase 3 trial that we're now leading to determine if checkpoint inhibitors used in the upfront setting can improve outcome in this disease. So this clinical trial is called ANHL 1931. This is a randomized phase 3 trial of nivolumab in previously untreated PNPCL. This is being run through the National Clinical Trials Network at the NCI. It's being led by the Children's Oncology Group, which really was developed along with all of the adult cooperative groups led by the Alliance group to be studied both in children and adults with PNPCL. The basic trial design is shown here. So the physician declares the chemotherapy backbone of either R-CHOP or dose-adjusted EPOCH-R, and then patients are randomized to standard of care or chemotherapy plus nivolumab for 6 cycles. The primary endpoint is progression-free survival as determined by independent review Discussions about RT were quite extensive in the design of this trial, and ultimately, in the interest of avoiding RT for the vast majority of patients on this trial, RT will be permitted in very limited situations. The two scenarios for which RT will be utilized in this trial are shown here. One, if the physician is declaring RCHOP, they have the option to declaring they are intending to treat with RCHOP plus radiation, regardless of end of therapy image. And there's also an option for RCHOP without radiation, but there is that option that if you are interested in RCHOP plus RT as your standard of care, that can be a mechanism for which patients receive RT. The only other scenario where patients will receive RT is if a biopsy at the end of therapy shows residual disease. We are not basing RT decisions on end of therapy PET, given the low positive predictive value. This will be and is open across all of the NCT network and all age groups. So the details of the more detailed schema are shown here. So there's three treatment options. One is RCHOP plus RT, and the others are RCHOP or dosage in EPOCH without RT unless biopsy positive disease at the end of therapy. Once the physician declares one of these three backbones, patients are then randomized to either standard of care or standard of care plus nivolumab. There's integral imaging after cycle 2. This is really just to identify those with progressive disease, and they go off therapy. And we're hoping to evaluate some modalities of the PET-CT that might be predictive at this time, but really it's a study question, not dictating therapy on this time. After 6 cycles, those patients who were in the RCHOP plus RT arm will go on to RT as planned, and those in all other arms will get an end of therapy PET-CT. Those who are in a CR as defined by Dover 1-3 will be observed. Those with frank progression by anatomic measurements go off therapy. And those who are in a PR or with stable disease can either be observed post-interval imaging or biopsy at the physician's discretion, and only those with a positive biopsy will go on. The primary objective of this study is to determine if nivolumab plus chemo results in a superior progression-free survival. And secondary objectives of event-free and overall survival, establishing the rate of positive PET at end of therapy, especially in the setting of a checkpoint inhibitor, which we don't yet know. We also have exploratory objectives where we'll be collecting stretch tubes to evaluate ctDNA and evaluating immune function in response to checkpoint inhibitors. As far as the statistical considerations for this trial, a lot of discussion about this. This is a very rare disease. This is not a trial where we would ever enroll thousands of patients as you would in a standard phase 3 trial. And so we have adjusted the statistics accordingly. Assuming an 80% progression-free survival in the standard arm with a one-sided alpha of 0.05, we have 80% power to detect a hazard ratio of 0.3 with Evo, which equates to 92.8% progression-free survival in the experimental arm. If accrual is robust, we will convert to a one-sided alpha of 0.025. This requires 186 evaluable patients, and we're estimating this will accrue over just under. The criteria for end of therapy imaging are shown here. This is modified criteria based on our understanding of PET-CT in this disease, where a negative PET will be considered a complete response, but a positive PET is not used to determine response. And in that case, anatomic measurements are used to define partial response, stable, or progressive. The radiation that's being given in this study is shown here, 30.6 gray for those in the RCHOP plus RT arm, and all others will receive that dose plus a boost to any avid area and proton therapy. So to summarize for this trial, this is the first randomized phase 3 trial that will evaluate checkpoint inhibition in this disease. This truly was a collaborative effort through all of the NCTN clinical trials network cooperative groups and across ages. This will enroll both pediatric and adult centers and has been open since June of 2021. And so we're very excited to get this up and going and hopefully to be sharing over the years the data from this trial with all of you. And then my final slide here, whenever we discuss this disease, I think it's important to focus on the age group that we are talking about, and this is adolescents and young adults. And so while a lot of our time is spent understanding the biology and the treatment of the disease, I think the holistic care of these patients can't be ignored. And our team has adopted the adolescent and young adult care model that's outlined here, which we think really provides optimal care for our patients and the ability for our center to be able to advance outcomes in this historically underserved group. This is a group of patients that could walk into a pediatric oncologist or an adult oncologist, and if they're not working together, receive vastly different treatment recommendations and different access to clinical trials. So our team has a joint initiative between pediatric and medical oncology to treat these patients in one single center. To offer seamless care from diagnosis through survivorship. This includes before treatment, things like fertility preservation, during treatment, things like symptom management, integrative medicine, and then after treatment, importantly, linking these patients in with our survivorship program for long-term follow-up to manage and surveillance for long-term toxicity. We have dedicated support staff, including psychology and social work, and then a robust both clinical and basic research program studying adolescents and young adult lymphomas. This includes a clinical research nurse, clinical research associate, and an AYA research portfolio that is consisting of both our laboratory researchers and our clinical researchers working on programs such as this joint clinical trial to advance care for patients. So to conclude, PMBCL is a very distinct both molecular and clinical entity that has overlapping features with Hodgkin lymphoma. I think our goals here, as always, need to be to improve outcomes while minimizing long-term toxicity in this vulnerable population. And cross-network collaboration between pediatric and medical oncologists will enable the large prospective trials that are needed to advance this. And so I'll conclude by acknowledging my collaborators who have worked on the trial that I outlined here. This includes members from Children's Oncology Group Alliance, Southwest Oncology Group, and ECOG, who have been a very collaborative and wonderful team to work with as we develop this trial. I also want to thank all of you for joining today and listening, and I'm happy to stop and answer questions and discussions. Thank you.
Thank you so much, Dr. Lisa, for that wonderful presentation. We have now some of the Indian faculty who would like to ask their difficulties to you. Can we begin with Dr. Sachin?
Good evening. My question to you is, for those patients with relapsed refractory PMBCL whom we treat with immunotherapy with nivolumab or pembrolizumab, generally, how long do you expect the responses to last? And would you like to consolidate such patients with an allo transplant?
Yeah, so it's a good question. I think we don't know how durable those responses are. I've been treating patients in a CR to autologous stem cell transplant. So there's not any data to suggest that allo is superior in this disease. And so, first line, if you get a patient into a CR with a checkpoint inhibitor, I've been using autologous stem cell transplant.
No, for post-auto relapses?
For post-auto relapses?
Yes, for post-auto relapses.
Oh, yeah, then absolutely I would consider an allo or CAR T in those patients.
Right. There's one more question which does concern to immunotherapy itself, that in spite of having biological similarities with Hodgkin's lymphoma, why is it that the outcomes with nivolumab or pembrolizumab are not so great in PMBCL as compared to that in Hodgkin's lymphoma?
I mean, I think it is a distinct entity. I think, it has similarities. It does have a high response rate. I think we don't know as much about the immune microenvironment to understand, what are the nuances between Hodgkin lymphoma and PMBCL that might lead to slight differences in response rates. Also, surprisingly, the poor response to single agent brentuximab vedotin, and is that related to the immune microenvironment as well, and the role that BD plays in the immune microenvironment, and could that explain the difference? I mean, this is largely CD30 positive tumor. This is a tumor where I would have expected much better response rate, even to single agent BD that we haven't seen.
Thank you.
Thank you, Sachin. One question from the audience. How frequent is the CNS relapse? and how do you manage them?
We do see CNS relapses. So the majority of those cases are parenchymal CNS disease. And we often treat those as we go to primary CNS lymphoma. So focusing on high dose methotrexate regimens, and also, trying to get those patients to autologous stem cell transplant if possible. But we do see not infrequently, among the relapse, which is the minority of the population, but we do see CNS relapse, and they tend to be parenchymal brain lesions. So I do take very seriously any neurologic symptoms in a patient with relapse disease, to have a low threshold for MRI of the brain to evaluate for CNS relapse. And then in those cases, treating that like a primary CNS lymphoma with a high-dose methotrexate regimen.
Thank you. Another question is there a role of interim PET scan?
Yeah, we don't know. So we get interim PET scans, and they're almost inevitably PET avid after 2 cycles. So we're not acting on those imaging results, other than if the patient has progressive disease. But there's not any evidence that we have on interim PET to dictate that a positive PET at that point is any negative prognostic value. The vast majority of patients are still PET avid at interim imaging. So we all get interim imaging because we're used to doing it, but I don't act on that unless there's progressive disease, especially now that especially in this trial, moving checkpoint inhibitors up front. We want to be very careful about how we're interpreting interim imaging, particularly PET uptake on interim imaging on patients with checkpoint inhibitors, so that we're not labeling false progressions.
Dr. Chandran, your question? Do you have a question, Dr. Chandran?
It was regarding the same only. So how do you do an interim response assessment? And depending on the response, how do you take it forward? So it's already answered.
Yeah, I think we're just kind of on autopilot with 6 cycles. And we all kind of want to check in the middle because we're so used to doing that. But I don't act on interim assessment.
Yeah.
Dr. Sandeep Shah?
Yeah, after completion of treatment and achieving complete remission of PET-CT, how do you follow this patient with PET-CT or with HRCT thorax?
Yeah, no more PET. I don't do any more PET-CTs. After 6 cycles, if you have a negative PET, I certainly don't do any more PET imaging. I think you're just very prone to getting false positives there. I do perform interim imaging on these patients at about 6-month intervals, and that's how we have it written in the clinical trial as well, is 6-month intervals of CT imaging to evaluate for any anatomic evidence of relapsed or refractory disease. But I would not perform any more PET-CTs after you have a negative PET-CT.
Yeah. Second question is, after treating patient with ARCH of 6 cycles, and if PET is positive, will you give radiotherapy straight away, or we will confirm by biopsy and then radiotherapy?
Yeah, that is very good. That's a question I don't have the answer to. So I will say, different practitioners will approach that differently. So Kiri Savajan, her recent blood publication, uses end of therapy PET in the setting of RCHOP to dictate who receives RT and administers RT for those who are PET positive after 6 cycles of RCHOP. On our trial, we kind of hedged our bets here, and if there were practitioners that really wanted RT with RCHOP, we could declare that, but not as dictated by PET. We also think it is reasonable to watch those patients, consider a biopsy to help guide your decision. But as you know, there's no prospective trial to answer that question. That's why I personally am more comfortable with dose-adjusted EPOCH-R and avoiding RT in the context of a higher intensity chemotherapy regimen. But I recognize not all centers have capacity for infusional chemotherapy, and for a variety of reasons, RCHOP might be used over dose-adjusted EPOCH-R. And then the question of end of therapy RT, especially in the setting of a positive PET, is a very challenging one, for which I don't have the answer.
Thank you. Thank you.
Thank you. There's one question about use of rituximab in relapsed setting. Would you assess CD20 positivity and then decide, or give it randomly to all?
I encourage a repeat biopsy for all relapsed cases. And so and CD20 assessment, of course, would be part of that biopsy. The vast majority remain CD20 positive. I do use rituximab in the relapse setting and feel comfortable with that. You could also use another anti-CD20, would be appropriate as well. But I think repeat biopsy to evaluate for kind of all of the immunohistochemical characteristics of the disease are quite important. I have certainly seen cases where, at relapse, this looks more like Hodgkin lymphoma, looks more like gray zone lymphoma. And the treatment for those actually is relatively straightforward because the treatments have overlapping activity between gray zone and Hodgkin lymphoma. Nivolumab and brentuximab are active in all of those, but I think it's important to understand the histology that you are dealing with. If you have a gray zone lymphoma at relapse, you're not going to treat with radiation alone, for example, and you're going to push much harder to get that patient to auto stem cell transplant. So biopsy is essential here, including evaluations.
There was a question about this post-auto relapse, and you mentioned about CAR T and allo transplant. What is your preference between the two?
I don't have any data to support one versus the other. I have been using CAR T based on the response rates that we've seen, albeit in small numbers. And I think the bigger question is what is the durability of the response to CAR T, and we just don't know yet. But that is a patient that I would take to CAR T if you harvest.
One question is related to, as patients relapse in CNS, are there any predictive factors?
Not that I'm aware of, very small numbers, and we don't even have large series of kind of relapse PNBCL as a whole. So I don't have data on predictive factors for relapse CNS disease.
There's a question whether the males do have more aggressive disease and do poorly.
I'm sorry, ask that again.
Do males have a more aggressive disease and overall do poorly?
So I'm not aware of any studies that have identified sex as a risk factor. A lot of studies have evaluated what are the negative prognostic risk factors for this disease with varying results. And so when we were writing the trial to design that, we were kind of determining, is there something that we should be risk stratifying these patients by? I think the things that have come out as poor prognostic factors are elevated LDH and bulky disease. The vast majority of patients, however, often do have that. So it's really, we don't really have great markers of risk stratification up front. And that's why, this is one of these lymphoma subtypes where with all stages, all comers are treated with the same therapy because we really don't have good prognostic markers of, who is likely to relapse based on upfront characteristics.
One question about, is there any data on ibrutinib?
Not that I'm aware of. I haven't seen any data on ibrutinib.
And another question is about polatuzumab. Is it effective?
Yeah, all of these we extrapolate from diffuse large B-cell lymphoma. And so I do get questions about this, kind of all of the novel agents that are being studied in DLBCL, because most of these are, CD20 targets or CD30 targets. Is this something that we should try in this disease? This is such a rare diagnosis that prospective trials with these agents they don't exist. So I'm not aware specifically of any data for ibrutinib or polatuzumab specifically in cancer.
There's a question that if you have a Deauville score 4 or 5 after the treatment, how do you justify observing?
So I can say, based on the NCI trial, they reported among their 88 patients, and you can go back and look in their paper, they've outlined the treatment failures and the treatment successes by end of therapy Deauville score. And the vast majority of the Deauville score 4 patients are treatment successes. And among the treatment failures, there's certainly, it's enhanced with Deauville 5s for sure, but there's Deauville 2s, there's Deauville 3s. It really is a mix. And so it seemed uncomfortable to me at first too, but as I have followed more and more of these patients, especially the Deauville 4s without anatomic progression, especially those that have been treated with a dose-adjusted chemotherapy regimen, the vast majority of these can be followed with no further therapy. Close interval imaging, and I even recommend CT-based decision making. So not, it's going to be persistently PET acid for quite some time, but I mean, the event-free survival of a patient with Deauville score at the end of therapy is 75%. So 75% of those patients are going to be just fine with no further therapy. And this is a patient population that I really do think it's important to avoid RT. This is very high dose RT in a predominantly female population.
Last question is, for a massive pericardial effusion, which is persisting, is there a role for intrapericardial rituximab?
I have not done that. I have not done. So I don't know if it's the disease burden there or just kind of the massive burden surrounding. So intrapericardial rituximab is not something I can comment on. I have seen intrathecal rituximab used in some cases, but never intrapericardial. But interesting to think about. The majority of these, just a drain and then eventually.
Thank you so much, Dr. Lisaro. That is the last question. I'm extremely grateful to you for accepting the invitation and educating us on this particular disease. There was a lot
Thank you so much for having me. It's been a pleasure, and I look forward to one day being able to come in person.
Thank you. A wonderful day ahead.
Thank you.
This brings me to introducing the third speaker of the day. And we have Dr. Jennifer Crombie from Department of Medical Oncology, Dana-Farber, Boston. She's going to speak to us about adult Burkitt's lymphoma. Over to you, Dr. Jennifer.
Thank you. Let me share my slides here. Okay. Good morning, everyone, or good day, depending on the time. As you just heard, my name is Dr. Jennifer Crombie from Dana-Farber, and I just want to start by thanking everyone for the invitation to speak to you today about adult Burkitt lymphoma. I wanted to start the talk by going through a case. I'm just going to actually mute my email here before I get going. Sorry about that. So I wanted to start by going through a case. This is a patient of mine. She is a 51-year-old woman who was otherwise healthy with a history of anxiety, and she presented to our emergency room with a groin mass. She had a CT scan when she arrived that showed diffuse lymphadenopathy, and ultimately a PET scan, which you can see here, that showed FDG uptake within lymph nodes within the stomach and the peritoneum. The SUVs on the PET scan were as high as 33. She had an LDH of 433. Her uric acid was normal, and her other serum chemistries and CBC were unremarkable. She went forward with an excisional lymph node biopsy. This showed sheets of intermediate to large atypical lymphoid cells. They had a high mitotic index and a patchy starry sky pattern. The cells were positive for CD10, CD20, MYC, BCL6, and EBER. They were negative for BCL1, BCL2, CD23, and CD30. And the Ki67 was 100%. She had FISH studies that showed a MYC rearrangement and no BCL2 or BCL6 rearrangement. And she had a lumbar puncture that was negative for any disease involvement. Is someone having a question or? See a hand up?
Oh, please go ahead.
Okay. So in thinking about this case, I wanted to just propose a few questions to think about as we go through the talk today. One, what is the most likely diagnosis? And if you do think it's Burkitt lymphoma, what other lymphomas would you be considering in this case? What is the prognosis for this patient and for Burkitt lymphoma in particular? And then lastly, what is the treatment that you would select for this patient, taking into account her clinical factors and age? And so my hope today is as we go through this talk, we can go through some of the newer data to help refine the answers to those questions. So I'm going to start by talking about the clinical features of Burkitt lymphoma, focusing on the specific subtypes and the pathologic and genetic features that define this disease. I will be going over some of the new data that that talk about prognosis and how we can better inform our patients or think about how our patients are going to do going forward when we first meet them. And then lastly, I'll go through the various treatment options and how we can apply these treatment options to particular patients. And then lastly, we can touch on some of the emerging therapies for this disease. So we'll start with the clinical features. Burkitt lymphoma falls in the subgroup of non-Hodgkin lymphoma. It's a B-cell lymphoma, and it's in the aggressive lymphoma category. You can see here this figure from the WHO update that Burkitt lymphoma shares many morphologic and phenotypic features as other aggressive B-cell lymphomas, such as diffuse large B-cell lymphoma and high-grade B-cell lymphoma. It's relatively rare in adults. It represents only about 1% of the non-Hodgkin lymphoma cases that we see, and it is more common in the pediatric population, where it represents closer to 20 to 30% of lymphomas. And across the globe, we see about 1,000 cases per year of this disease. As many of you may be aware, the Burkitt lymphoma was the initial descriptions dated back to the early 20th century, but it was more formally named in the mid-1950s when a surgeon named Dennis Burkitt went to Africa and observed many children presenting with a similar phenotype of large jaw tumors and some children with large abdominal tumors. And initially this was described as a sarcoma, but later was classified as a lymphoma and named after Dr. Burkitt. While the disease was initially thought to be specific to the sub-Saharan African region of the world, we have since recognize that this subtype of lymphoma can be seen across the globe. And so since then, the WHO has classified Burkitt lymphoma into a few different subgroups. The first is endemic Burkitt, which is the subtype that I was alluding to before. We see this most commonly in pediatric patients, more common in boys than girls. It's highly associated with EBV and specifically associated with co-infections of malaria. In sub-Saharan Africa, this disease is most commonly seen in areas where malaria is holoendemic. Patients typically present with jaw masses, and it's very common to see extranodal involvement. The other subtype, which we're more used to seeing, is the sporadic subtype of Burkitt, which is seen in the US and Western Europe. This is also more common in pediatric patients and with a male predominance. Extranodal disease is still common, as is CNS involvement. And when we see it in the CNS, we're much more likely to see this as leptomeningeal disease rather than parenchymal disease. EBV still can be associated with this entity, though it's rarer than endemic Burkitt, about 25 to 40% of cases in various series. The last subgroup that I wanted to mention is the immunodeficiency associated subgroup. And this is when we see Burkitt lymphoma arising in the context of an immunodeficiency, most notably HIV infection. What's unique about this subgroup and different from other lymphomas or cancers that occur in the context of immunocompromise is that this can occur even with preserved CD4 counts. So even in the era of antiretroviral therapy and higher CD4 counts, patients with HIV can still be predisposed to developing this subtype of Burkitt lymphoma, and nodal involvement is more common here. So how do patients typically present with Burkitt lymphoma? There was a recently published real-world analysis across 30 different centers in the United States that helped better characterize this, given the rarity of the disease. This was a very helpful descriptive paper to be published. This was just this year. And in this large series, about 20% of patients presented with CNS involvement almost 80% had advanced stage disease. So that seems to be probably what we're used to seeing in clinic, but now have a better understanding of it. And as we know, again, a male predominance is seen with Burkitt lymphoma. It typically affects younger patients. The median age across this series was 47, though, as you can see in the range, that's quite, a broad range, 18 to 88 years, and about a quarter of the patients were over 60 years of age. And as we'll get to, this group really continues to represent a therapeutic challenge for this subtype of lymphoma. So when we see a patient like this in clinic, how do we make the diagnosis? It's very important to get baseline labs, critical to monitor for tumor lysis syndrome. Many patients can present with spontaneous tumor lysis. I do check hepatitis and HIV testing in all patients, and I would do a diagnostic lumbar puncture in all patients. If there's any concern for other neurologic changes, I would get an MRI as well, and then a baseline PET scan. It's often critical to make these diagnoses quickly because of how quickly the disease can progress. And so often in my experience, I've treated these patients or worked them up in the inpatient setting, though on occasion, someone may have a lower burden of disease. Once you have done that, the important next step to make the diagnosis is obviously to get a biopsy. And as many people are probably used to hearing, Burkitt has a very classic description on its pathology, which is the starry sky appearance. And these biopsies have real complete effacement of the lymph node. The cells are typically uniform, similar size, and have prominent nucleoli. Like the case I presented, the Ki-67 is often approaching 100%. And the hallmark of Burkitt lymphoma is the presence of a MYC translocation, most commonly translocation 814. The typical immunohistochemistry that we see for Burkitt lymphoma is the B cell markers. And then notably, it's usually negative for some common stains that we use in aggressive lymphomas, such as BCL2. So that's an important one to be aware of, especially as it's often difficult to distinguish Burkitt from diffuse large B-cell lymphoma, where that can be positive. The same with CD5, that can be positive in diffuse large B-cell lymphoma. So that sort of is a lead in to how can we distinguish Burkitt lymphoma from other aggressive B-cell lymphomas. So I put this figure here. This can be helpful if you're ever in the situation where the pathologist is not quite sure, or you have information and it's not specified. Burkitt lymphoma, much more common to have this uniform appearance, B-cell markers, MYC translocations, and some features that can help you distinguish it are the high-grade B-cell lymphomas, or DLBCLs, are more likely to have BCL2 positivity and can be more heterogeneous in size with larger cells. I also wanted to just bring to your attention this pathologic diagnosis of Burkitt-like lymphoma. This is when we see a Burkitt lymphoma histologically, but there's no MYC translocation. These lymphomas are typically associated with 11q aberrations. And as we'll get to, this is really has a unique genomic profile and is really kind of considered as a separate entity from Burkitt lymphoma, though histologically looks quite similar. I mentioned that the translocation in MYC is a genetic hallmark of Burkitt lymphoma, and this was really one of the lymphomas where we started to see how the genetics can play into disease pathogenesis early on. The majority of cases have the translocation of MYC with the immunoglobulin heavy chain, though about 20% of cases can also have translocation of MYC with the kappa or lambda immunoglobulin light chain region. So that's translocation 822 or translocation 28. So just worth being aware of those less common MYC aberrations that you can see with Burkitt lymphoma. So even though we have some tools to help us distinguish Burkitt lymphoma from other lymphomas histologically, it still can sometimes be a challenge. We know that there are studies, these are quite old now, but there were studies looking at gene expression profiling data and looking at these in Burkitt lymphoma as compared to other lymphoma subtypes. And you can see here that diffuse large B-cell lymphoma and primary mediastinal lymphoma had a very distinct gene expression profile as compared to Burkitt lymphoma. And if you look at the specific target genes, this is from the same paper, that Burkitt lymphoma, as expected, has an enrichment in expression for MYC target genes, which is quite different from other aggressive lymphomas where these are typically low. And the Burkitt lymphoma usually arises from germinal center B cells, so they have expression of germinal center genes. And unlike diffuse large B-cell lymphoma, they typically have low expression of NF-kappa B target genes. So this is another way to distinguish. Unfortunately, these tools are really limited to the research setting and not available for clinical use by the pathologist, but it's at least more confirmation that these are distinct and behave differently from aggressive lymphomas. More recently, there's been papers published that have provided further insight into the genomics of Burkitt lymphoma and the key signaling pathways that result in disease pathogenesis. One of the key pathways that has been identified through a combination of whole exome and RNA sequencing are the identification of both ID3 and TCF3 mutations, and these can occur in up to 70% of Burkitt lymphoma patients. And the TCF3 is involved in the centroblast cell and signaling and growth within that cell. So that is a common mutation that we can see. And then there's also been recurrent mutations that have been identified that are involved in PI3 kinase signaling, cell cycle regulation, apoptosis, and cell proliferation. So these are just, we're learning more about these, and hopefully in the future, though not quite yet now, can use these to help personalize therapy or use more targeted therapies in this disease. We're just not quite there yet. I also wanted to just highlight the role of EBV. EBV, as you know, is a ubiquitous human herpes virus, and it has a unique tropism for B cells. While this is very common in the population, in a subset of patients, it can predispose them for lymphomas, and that's what we're seeing in the endemic subtype of Burkitt lymphoma. And interestingly, what we've seen through a combination of sequencing transcriptome data, that the EBV status really does seem to be quite important in determining the genomic underpinnings of the Burkitt lymphoma cells. So here, this was a study that looked at both endemic and sporadic Burkitt lymphoma, as well as EBV negative and EBV positive lymphomas. And interestingly, it seemed that the EBV status was more important than the geographic region in characterizing the underlying genomics. So the EBV positive tumors had fewer drivers of malignancy, but they had a higher mutational burden. And this is probably has to do with this underlying mechanism of impaired aberrant somatic hypermutation. So it's kind of raised the question of whether the Burkitt lymphoma classification that we currently use, which is by geography, is actually the correct classification, or should we really be thinking about the role of EBV when we think about how best to subgroup Burkitt lymphoma subtypes. And then I mentioned this entity earlier. I put this paper in just to highlight that Burkitt-like disease, when the patients do not have a MYC rearrangement but have 11q aberrations. These patients have been compared to patients with Burkitt lymphoma in terms of their genomic profiles, and they really are a distinct entity. So it's just important to note that these are probably, even though they look the same, quite different diseases. So that's the sort of background that I wanted to provide in terms of the clinical features, how patients may present, and some of the pathologic and genomic features of Burkitt lymphoma. So I wanted to next move on to the prognosis and how we can think about refining how we tell patients how they're going to do. I did see a question come through, and I can maybe address all the questions at the end, because we'll get back to the clinical case once we go through a little bit more of the details. But I did see that. So overall, a take-home message is that Burkitt lymphoma is associated with very favorable outcomes with intensive therapy. This is from that same paper that I mentioned before, a real-world experience in the United States, looking at how patients do with Burkitt lymphoma. This was a large series, and the 3-year PFS in this paper was 64%, and the overall survival was 70%. So this, I think, is quite good for an aggressive lymphoma. However, in the original papers that many of you may be familiar with, where they looked at the different treatment regimens, including the modified McGrath regimen or dose-adjusted R-EPOCH, which we're going to get into in a little bit, the protocols have defined risk groups based on clinical features. And they've defined a low risk group typically as patients with a single site of disease, non-bulky disease, normal LDH, completely resected completely resected disease. And patients defined as low risk typically have been treated with less intensive treatments in the context of these clinical trials. And while we had these risk groups to try to think about how to treat patients, we haven't had a really good prognostic model to deal with the majority of patients who present with high risk disease. Only about 10% of patients will present in one of these low risk groups. So that's really been sort of an unmet need in the field of Burkitt lymphoma. Thankfully, this has been looked at recently in the context of this large study. This large collaboration was able to address a variety of different factors to see which variables seem to impact outcome in Burkitt lymphoma. Interestingly, it did not seem that the induction therapy had much of an impact on outcome. They looked at commonly used regimens for Burkitt lymphoma, including modified McGrath, dose-adjusted R-EPOCH, and hyper-CVAD, which is preferred aggressive therapy in some centers. Not surprisingly, the use of rituximab had quite a large impact on outcomes. The 3-year progression-free survival in patients who did not receive rituximab was approximately 40%, while patients who did receive rituximab was closer to 6 to 70%. So it's really important, as we do with most of our aggressive lymphomas, to think about adding rituximab when able. And we've seen this now across the histologies, the importance of CD20 antibody therapy. Another factor that they looked in this particular study was whether the location that the patient received therapy had any impact. And not totally surprising, patients who were treated in a larger academic center seem to have improved outcomes as compared to patients who were treated in the community. And this probably reflects the complexity of Burkitt lymphoma, that patients often do present quite sick. They need expedited diagnoses and evaluations. And then lastly, as I mentioned before, the treatments are quite strong. So hospitals have to be well equipped to deal with complications that may arise, including infections and cytopenias and other side effects that can arise from treatment. Importantly, younger age is a very important factor that correlates with improved outcomes. In this large series, it seems that patients who are younger than age 40 seem to have improved outcomes, while patients who are 40 and older seem to have sort of a similarly poorer outcome, and that the 3-year OS was about 80% in the younger patients and closer to 65% in the older patients. And then I included this paper as well, the second figure. This is a pediatric study where children with aggressive B-cell lymphomas, in this particular study, there were about 85% of the patients had Burkitt lymphoma, were randomized to intensive chemotherapy with or without rituximab. And what's notable is that either arm, with or without rituximab, the 3-year event-free survival is quite high, 82% versus 93%. So the children are doing better even without rituximab than the adult population. It's hard to know if this difference is a biologic difference. There's something different about children's disease versus adult disease, but more likely it may just be that the patients do better with very intensive therapy, and the older patients just may be less able to tolerate the high intensity therapy that's required to cure them of their lymphoma. So putting these factors together, this group kind of picked out the key clinical features that seem to correlate with outcome. And the ones that have sort of come out as independent prognostic variables included age over 40, a lower performance status of 2 ECOG performance status of 2 to 4, an LDH that was 3 times the upper limit of normal, and of course CNS involvement. And as you can see by these figures, these variables very clearly correlated with outcomes and provided a very nice separation. So they looked at patients who had 0 factors. Their progression-free survival at 3 years was over 90%. 1 factor was closer to 70%. And then if you had 2 or more of these, that did bump you into a higher risk group where the progression-free survival was closer to 50%. So this is really helpful to have when meeting a new patient and thinking about how to counsel them and thinking about how they may do with this disease. This single study then was validated in a follow-up paper. This was recently published in JCO. The initial cohort included 633 patients across the US. And then in this paper, there was a validation cohort in Europe, Canada, and Australia. And here they just essentially validated this prognostic model in this separate cohort. And again, clearly showed the differences ranging from 92% in the low risk group to 53% in the higher risk group, progression-free survival at 3 years, depending on the number of risk factors that you had. So this has sort of been new as of this year, identified as the Burkitt lymphoma IPI. So you probably will be hearing more about this. People often ask about HIV. As I discussed earlier, there is a separate category of Burkitt lymphoma that's associated with immunodeficiency, and wonder, does HIV predict poor outcomes? And interestingly, that does not seem to impact overall prognosis for patients. I put up 2 studies that included patients with HIV. The first was a small cohort of 34 patients with HIV-associated Burkitt lymphoma who were treated with the modified McGrath regimen, and their 2-year overall survival was close to 70%. Still a very small study, but I think it just highlights that patients with HIV can do well. And the recent, our EPOC study, which was for patients with Burkitt lymphoma, did have a cohort of patients that were HIV positive, and they found that the outcomes in that subgroup, again, small numbers, showed that the outcomes were similar to the HIV negative population. Unfortunately, the endemic Burkitt lymphoma remains a challenge, and the outcomes of this disease, even though these are children, and we saw the data that shows that pediatric patients with sporadic Burkitt lymphoma do quite well with progression-free survival of over 90%. In endemic Burkitt lymphoma, the outcomes remain poor. This was just a review article that kind of collated outcomes of various treatment options available in the endemic Burkitt lymphoma studies. And as you can see, the 1-year overall survival is closer to 40 to 60%. And the treatment-related mortality is quite high in these studies. I think this highlights just the less access to care and ability to support patients through intensive treatment strategies. So hopefully this is something that with time we can improve upon, especially as we know we have treatments that can cure children with Burkitt lymphoma. But people have wondered, is it biologic differences between endemic and sporadic Burkitt lymphoma? I do not think that's the case, especially as we saw some data that it seems to be EBV status rather than geographic region. I suspect it's more of a resource limitation that's driving those differences in outcomes. So I think that's really all I wanted to talk about for prognosis, and just really highlighting this new Burkitt lymphoma IPI that's recently been published. And I'll move on to the treatment. We've already talked about how outcomes are favorable, and I put this as from a recent review article that I wrote that just highlights the different treatment options. Burkitt lymphoma is very rare. There are not large randomized studies to know which is the preferred treatment strategy for patients who present. All of these are single arm or older studies that showed high response rates, and it's typically provider discretion which regimen is used, and it may be somewhat variable depending on what center the patient is being treated at. But across these different studies and using these various regimens, you can see, as we saw in the real world experience, the outcomes are quite high. I wanted to highlight, before I dive into the different treatment options that I typically think about, the role for pre-phase therapy. And this is, I think, quite important for Burkitt lymphoma. We talked about previously how patients with Burkitt's can present with high burden of disease. Almost 80% of patients have advanced stage disease, and it's very common for patients to have tumor lysis or spontaneous tumor lysis. And particularly for frail patients or those who, because of their lymphoma, may have baseline abnormal lab values, it's important to think about the use of pre-phase therapy. And some pre-phase therapies have even been incorporated into clinical trials. And what I mean by that is just using a steroid lead-in. Sometimes this may be prednisone alone. We've also implemented Cytoxan pre-phase approaches where we may give 5 days of Cytoxan to try to limit tumor lysis and stabilize the patient and potentially improve their labs before moving forward with combination chemo. So that's just a strategy to keep in mind. Don't think you lose anything and potentially can prevent the patient from getting too sick. So the first regimen that I wanted to talk about is the McGrath regimen. This regimen alternates two different chemotherapy approaches, the Codox-M and IVAC approaches. And so this was from an old paper now, 1996, the study was published that showed superior outcomes with this regimen as compared to prior data of using CHOP with methotrexate alone. So that really did not seem to be an adequate strategy for this subtype of disease. In the initial study, the outcomes did seem quite high. The 2-year EFS was over 90%, but this was a very small study. There were 40 patients, and there was also a really young patient population. The median age was 25. Follow-up studies had been subsequently performed where patients were slightly older, more of a median age in the 30s, and about 20% of patients were unable to complete the therapy due to toxicity, and they saw a lower 2-year event-free survival. Given that, there's subsequently been the modified McGrath regimen, where the dose of methotrexate has been modified, cytarabine dose can be modified, and this is associated with an improved tolerability. The 2-year progression-free survival, though, is slightly lower than what we saw in that initial study, closer to in the 64% range. But again, we now have better tools to distinguish who is going to do better and who may be the people with poor outcomes. And this approach does take into account low versus high risk at onset. So it's important to look at factors like LDH and the presence of, or not, of bulky disease, because patients, the rare patients who do fall in this low risk category can get away with just the R-CoDox-M approach, and higher risk patients would have 4 cycles alternating R-CoDox-M and R-IVAC. This regimen also does incorporate an intrathecal therapy, and if CNS disease is positive, there are more doses of intrathecal therapy administered. The other regimen that I wanted to talk about is dose-adjusted R-EPOC. This was a study that was done in 2013 at the NCI, and this was a small study, but the responses were very high. The freedom from progression of this study was 95% with this regimen, and this this is slightly easier to tolerate than the modified McGrath. So people have wondered, how does this compare, and should this be one strategy that we're using more frequently? And this study also did kind of designate low versus high risk as in potentially patients with lower risk disease getting fewer cycles of chemotherapy using a PET response-based strategy. So a follow-up study of the same regimen done at the NCI. This was published within the last year. This was a larger study that included 113 patients and has had now longer follow-up. And so I think we now can see that the event-free survival is in the mid-80s, and outcomes were quite good with this approach. So I think this is just a larger study to support the use of this strategy in patients with Burkitt lymphoma. I showed you the retrospective data previously that the addition of rituximab improves outcomes. Most of the data that support the use of rituximab are single arm studies that were compared to historical controls, but there was one randomized study that compared the LMB regimen with or without rituximab in adults and showed a significant improvement in event-free survival. So all of our strategies are going to be incorporating in rituximab for this disease. I wanted to highlight treatment specifically for CNS disease. We talked about how about 20% of patients will be presenting with CNS involvement at the time of diagnosis, and this really remains a major challenge for in the field. Leptomeningeal disease is most common, but this just sort of highlights the breakdown: 15% leptomeningeal, 3% parenchymal, and then 1% was not specified in this particular paper. And I've alluded to this in the other study, but highlighting it again in a separate analysis, that patients with CNS lymphoma, a CNS involvement of their Burkitt's do much worse than patients who do not have CNS involvement. So when thinking about treatments, we don't have randomized data to really support this, but some are wary of the use of the R-EPOC regimen for patients with CNS involvement. The modified McGrath regimen does have high-dose methotrexate as well as cytarabine, both agents which can cross the blood-brain barrier, and those are administered systemically. It also includes intrathecal chemotherapy, whereas in the R-EPOC approach, intrathecal chemotherapy is the primary mode of treatment. And so you can see here, when in this particular study, when they looked at outcomes, based on CNS involvement, that the patients did do quite poorly if they had CNS involvement. So this has led many to favor modified McGrath if possible for patients who are able to tolerate it if there's a question of CNS involvement. And then this study just sort of looked at risk of CNS relapse in patients treated with the various regimens. And you can see that it was higher in patients who had been treated with the dose-adjusted R-EPOCH as compared to the other regimens. So something to keep in mind. Once we get into the relapsed refractory space, there's not too much to say because there's not really any trials in this setting. Often providers will use regimens that we use in other aggressive histologies for relapse disease, but the takeaway message is that outcomes are extremely poor if a patient does relapse with Burkitt lymphoma. This was a retrospective study from a few years ago that showed that if patients had an early relapse of Burkitt lymphoma, the median overall survival was less than 2 months. And if patients had a late relapse, it was closer to 5 months, but still highlights that this is a really challenging situation and associated with very poor prognosis. There at least is one study that looked at, I believe this was a pediatric cohort, but the use of allotransplant in patients that can be salvaged in the relapse setting did seem to have favorable outcomes. This was a very small study, 15 patients were included in the transplant cohort, but it's something to keep in mind given the limited options that we have available and the poor prognosis, that it should be something that would be considered for these patients. And then another challenging situation we talked about earlier, that age is an important prognostic factor. The treatment of the elderly can be quite difficult. Poor outcomes are seen in this population, and one of the challenges is the treatment-related mortality can be over 10 and close to 20% in patients who are over 60 years of age. So in older patients, you're definitely going to want to lean more towards the R-EPOCH regimen if they can tolerate it. Some elderly patients can't even tolerate that approach. And I think you're really just left going back to the R-CHOP and methotrexate strategies, just knowing that there's going to be a higher rate of relapse, although still a reasonable strategy, and especially if it's the only one the patient can tolerate. Lastly, before we get to the questions that I see coming in, I wanted to just touch on some of the emerging therapies. And again, this is a rare disease, so unfortunately trials have not really been robust and that are focusing on Burkitt lymphoma, but there are just some things emerging in the field of B-cell lymphoma, and you may have heard about these in other talks that are may be applicable to Burkitt lymphoma. So the first I want to highlight is CAR T. I'm sure everyone is familiar with this, where T cells can be engineered to bind to antigens on tumor cells. In the case of lymphoma, it's CD19. We have a few FDA-approved CAR T cell options now available for aggressive lymphomas. We use these commonly in patients with diffuse large B-cell lymphoma and primary mediastinal B-cell lymphoma, but no patients with Burkitt lymphoma have been included in any of the clinical trials of CAR T. I think one of the major concerns is that it takes about 3 weeks to manufacture the product, and often Burkitt lymphoma patients, if they do relapse, are going to progress quickly, and this can be very challenging to even temporize their disease while awaiting CAR T manufacturing. But I did want to point out there's at least one published case report of successful use of anti-CD19 CAR T cell therapy for Burkitt lymphoma. And this is just shows the before and after PET scan image that they provided, and as well as some data to suggest that the CAR T cell did expand. The CRP went up, and there was some rise in concurrent LDH. The patient did experience cytokine release syndrome. Unfortunately, this patient subsequently had infectious complications and passed away, but I think it does highlight that this, I hope that is a strategy that we think about in the future for Burkitt lymphoma as we improve our manufacturing timelines. I think we're probably not there yet, or move forward with allogeneic CAR Ts. I think Burkitt would be a population that you'd want to think about using those strategies in. I've tried to give Burkitt one patient of mine with Burkitt lymphoma CAR T, and unfortunately the patient did pass away before the CAR T, right as the CAR T cells were manufactured. And but it's something to think about. And just some other emerging therapies to be considering or just have on your radar. These include bispecific therapies. Just like allogeneic CAR T cells may be an off-the-shelf option, bispecific therapies are being studied across aggressive and indolent B-cell lymphomas. These typically bind to different antigens, or bind to a CD20 plus CD3 on T cells, CD3 on the T cells and CD20 on the tumor cell, that can allow for enhanced cell killing by the T cell. And I think these would be interesting drugs to explore in this disease as well. And I hope that we do moving forward. And then going back to the genetics that I talked about in the beginning of the talk, there are a few signaling pathways that seem to be recurrently altered in Burkitt lymphoma, including PI3 kinase signaling. To my knowledge, there are not any particular studies looking at targeted therapies for Burkitt lymphoma, and I imagine they would have to be combined with other chemotherapy or with other agents given the aggressive nature of the disease, but it's just something that may be a consideration for treatment in the future. So with that, I wanted to kind of bring it back to the case that I mentioned in the beginning, who was a 51-year-old woman with stage 4 Burkitt lymphoma that was involving her stomach and peritoneum, as well as some larger lymph nodes, though did not have a significantly elevated LDH and did not have any evidence of tumor lysis. So based on her path report, this did seem consistent with Burkitt lymphoma. She had the starry sky pattern. She was negative for BCL2 and did have a MYC rearrangement. The Ki67 was 100%. So it did seem like in this particular case, Burkitt was most likely the diagnosis, and she did not have CNS involvement. So in going back to the IPI score for her, she had one risk factor, which was an age greater than 40. She did not have an elevated LDH. Her performance status was a 1 when I met her. And she did not have CNS involvement. So based on that, I could quote her that her 3-year event-free survival was 72% based on the IPI score. And then what treatment would you think about using for a case like this? She's an interesting age because she is in her 50s. So it's not totally clear what the optimal strategy is for someone like that. I ultimately chose the modified McGrath regimen for her. She was fit and didn't have other medical comorbidities and did do just fine with that approach. But it would also be very reasonable to give someone our EPOC. I think as people approach 60, we definitely would not want to be using modified McGrath given the toxicities. So her case probably could have gone either way. She thankfully did very well with modified McGrath and has been in a remission now for about 1.5 years. So that was really all I wanted to go through today, and I'm happy to take some questions.
Thank you so much, Dr. Jennifer. That was a beautiful coverage of all aspects of Burkitt's lymphoma. In fact, some of the questions in the question box you already answered in your presentation. We have faculty here from India. They can think of their questions and raise hand. Till that time, we'll take up some questions from the question box. Does IV methotrexate provide adequate cover for leptomeningeal disease?
Yes, if someone does have CNS involvement, we're going to typically be doing both systemic methotrexate and intrathecal methotrexate. That's how the disease would be treated with the modified McGrath regimen. And in the EPOC regimen, it's intrathecal chemo alone. But we do generally think of high-dose methotrexate being able to treat leptomeningeal disease.
Right. Dr. Sanjeevan?
Thanks, Dr. Jennifer. A very elegant talk. One generic question and one specific one. What's in your experience, the most common time when patient, we all know that relapsed Burkitt's is a bad prognosis, but what's the commonest after completion of treatment that you've seen people relapsing? It's within 1 year, it's more than between 1 to 2 years, or it's beyond 2 years?
I think like most aggressive lymphomas, the relapses occur early. So the relapses that I've seen have all been within 1 year, but for aggressive lymphomas, I usually think about the 2-year mark being quite important for relapse. So I would put Burkitt in that same category. The cases I've seen have been all relatively quick.
Yeah. And, one interesting, one of the slides in which you were discussing about prognosis, I just saw that although it was a marginal difference, if rituximab was given outpatient, the patients tended to do better than an inpatient rituximab. So any comments?
That may have been biased by the fact that the people who were inpatient may have been sicker. I think this was a retrospective analysis, so it's somewhat hard to tease out all the different factors at play. But if they were inpatient, there may have been other comorbidities that they had, or they may have been sicker at baseline that required them to be in the hospital. So I would guess that it was that, but I'm not 100% sure.
Thanks.
Thank you, Sanjeevan. One more question from the audience. If there are no CNS symptoms, would you still do a lumbar puncture?
Yeah, given that the risk of CNS lymphoma is or involvement is so high, up to 20%, I do always get a lumbar puncture. And if I'm doing either of these approaches, they all incorporate in the use of intrathecal chemotherapy anyway. So I typically will just send, at the time that I'm doing the first treatment, I will send the CSF for analysis, and then all that will determine is whether they need extra intrathecal chemotherapy or not. But yeah, I think it's always a good idea to send when you're giving the first prophylactic dose.
Yeah. One more question from the audience. Is there any data on autologous stem cell transplant for relapsed patients?
It's probably been done. I pulled up. There's not a lot in the literature on management.
Can you just give me 5 minutes? I'm in a webinar.
Mute yourself. Yeah.
Yeah, there's not a robust data on management of relapse Burkitt's, probably because the outcomes are so poor and it's so rare, because thankfully a lot of the patients do well. It would be a reasonable strategy to think about in someone who is chemosensitive, like we think about other aggressive B-cell lymphomas. But I think, unfortunately, a lot of patients are not in that situation where they are getting the chemosensitivity. We do have the data from the pediatric patients to consider allo, where they do quite well. So I would have to think about those approaches in a patient who had relapsed.
The question is, do you believe in the entity of Burkitt's leukemia, pure bone marrow disease, no lymph nodes at all?
I think this is an interesting question, and I think that my guess is this may be something that WHO decides to reconsider and put more into the leukemia category than the Burkitt lymphoma category. Right now, there is a TDT positive Burkitt lymphoma entity through that we think about, but my sense is we may see changes in that moving forward, but you can technically see that.
The second part of the question is, how do you manage them?
That one is a little trickier. I think that many of those may get an ALL-based regimen.
Right. Dr. Sandeep, your question.
Yeah, when we treat elderly patient with RDA-IPOCH, how do we cover CNS prophylaxis? After finishing all cycles or in between?
The regimen that they used was outlined in the recent paper in JCO, but they did get intrathecal chemo throughout their treatment. I think it was at least six cycles, but there's no issue giving intrathecal chemo with RDPOC. I actually have done it many times for even double hit lymphomas, and you can give it throughout. It's probably better not to wait till the end.
No, about high dose methotrexate.
Oh, in that regimen, they did not use high dose methotrexate. They did intrathecal. So it is challenging to use high dose methotrexate with EPOC. Are you asking if you should give it out back? I think we don't know. That wasn't how they designed that study, but it's a reasonable question, especially given the data that shows higher risk of CNS relapse with that regimen.
And if the ejection fraction is compromised in elderly patient, then what protocol should be the best?
For an elderly patient,
Yeah,
I think
elderly patient.
it depends on how fit they are. I've had some older patients who I think may be able to tolerate REPOC, but that is an intense regimen. So if they are quite frail, those are patients that I would plan to start with probably if they were sick or presented with extensive disease, start with like a Cytoxan prephase and move into probably RCHOP with high dose methotrexate if they can tolerate that. So that's a very reasonable strategy, but it's just, we know that the relapse rates are higher, but I would do it if I thought someone was, in their, late 70s or, too sick or too frail for EPOC.
Okay, thank you.
Dr. Sachin.
Hello, good evening. Thank you for that wonderful talk. My question is, when do you do CSF analysis, you just do a morphology or a flow cytometry also? And how do you take patients who are morphologically negative but flow cytometry positive for the lymphoma?
So I typically will send cell counts, I will send flow cytometry, and I will send cytology. It's pretty rare to have a cytology positive and be flow negative. I think the flow is usually more precise.
No, it's usually the reverse way around. Cytology negative, flow positive.
I would typically count that as positive if I saw the flow, and I don't want to undertreat somebody. So if I do have a positive flow, then I would favor adding in the additional intrathecal therapy. And so I do always send both, and I lean towards over-treating and under-treating if there's ever any discrepancy between the two.
And you use similar strategies for DLBCLs also?
For DLBCL, I don't routinely get a baseline lumbar puncture unless the patient has a particular high risk. If there's a lesion right near the spine, or they have
only in the high risk patients.
Yeah, in those patients, I would do the same strategy of doing a lumbar puncture. If there's any neurologic changes, I would get an MRI. You may be getting into it in other talks, but the use of prophylactic therapy for diffuse large B-cell lymphoma is a little more controversial based on some recent papers. So our group is continuing to debate this issue and, not using it as often as we previously were for prevention. In Burkitt's, I think the risk is clearly much higher for CNS involvement, and all of the published approaches include CNS prophylaxis and or even high dose therapy that penetrates the CNS. So I wouldn't fear. We have no data to suggest that it's not effective in this case. So I would not stray from the published strategies.
Sachin, any other question from any faculty here? If there are none, then I must thank Dr. Jennifer for doing a wonderful job. You covered all aspects of our kids.
Well, thank you so much for having me. It was great to be invited and to meet you all today.
Thanks. And we have Dr. Manoj Kumar for the official vote of thanks.
Thank you, Dr. Jennifer. Amazing insights, and we all learned
and they were all clinically relevant. Thanks indeed. Thanks is also due to two of our other international speakers who spoke tonight, Dr. Matthew and Dr. Lisa. They were quite insightful too. Our program director, sir, still smiling, 6th day. It is not just marathon, it is actually duathlon or triathlon for you. Still going strong, and last day is tomorrow, 5:45. Our chief guest for the evening today, Colonel Dr. Sanjeevan Sharma. Thank you, sir, for those pearls of wisdom and still there and asking your questions as well. All the expert panelists today, Dr. Sandeep Shah, Dr. Sachin, Dr. Mehboob Basade, Dr. Manoj Toshniwal, Dr. Mahesh, Dr. Sunil, Dr. Chandran, Dr. Deepak, Dr. Abha Dubey, and Dr. Ayan Bhattacharya. And sir, once again, it's a full house. Thanks is also due to all the delegates from various countries. A big thank you to you, India, Canada, UK, USA, Bangladesh, Sri Lanka, Myanmar, Malaysia, and a very interesting TV and Iraq. So that's a new addition to our armamentarium. Tomorrow is the last day for the lymphoma update, 5:45. This marathon is coming to an end. Please, please, please continue and log in at 5:45. Thank you so very much. Good night. Stay safe.
Thank you. Thank you so much, sir.
Thank you, sir.
Thank you.
Thank you all. Bye.
Bye, everybody. Bye.